Well, welcome to the first of what we hope will be a series of virtual conferences highlighting VA Health Services research focused on women veterans' health and healthcare. My name is Elizabeth Yano, although most folks call me Becky, and I have the privilege of being one of the leaders of the National VA Women's Health Research Network, representing VA Health Services Research and Development's, or HSR&D's, investment in using research to accelerate evidence-based improvements in the health and care of women veterans. The National VA Women's Health Research Network has been funded since 2010 to accelerate development, conduct, and implementation of research dedicated to continually improving women veterans' health and care. I lead a national consortium of over 300 researchers and clinician educators dedicated to collaborative research development, mentorship of early career investigators, and dissemination and implementation of research evidence into routine practice and policy. Today's conference represents the culmination of years of research partnered with VA's leaders in women's healthcare, frontline providers, and women veterans themselves to ensure that our research targets their needs and priorities. I want to thank Drs. Jody Caton from the Puget Sound VA Healthcare System and Elizabeth Patton from VA Boston, who co-lead our National VA Reproductive Health Research Collaborative. Under their shared leadership, this collaborative has successfully accelerated the design, conduct, and implementation of state-of-the-art research to systematically improve women veterans' reproductive health care and outcomes. Today's conference is the product of their combined vision, hard work, experience, and engagement of a tremendous group of speakers that I know you will enjoy. I also want to thank Dr. Adriana Rodriguez, our National Women's Health Research Network Consortium Program Manager, without whom today's program would not have been possible. Lastly, I have to thank my VA Women's Health Research Network partners in building and innovating in women veterans research. Dr. Susan Frayne at VA Palo Alto and Allison Hamilton at VA Greater Los Angeles. While they are not part of today's program, their creativity and dedication to delivery of evidence-based care to our nation's women veterans is reflected in everything we do in the Women's Health Research Network. That said, we would not be here at all were it not for the vision and support of Dr. David Atkins. Dr. Atkins has been Director of VA HSR&D Service since 2013, for which he oversees a $100 million intramural health services research program, comprised of approximately 1,000 funded investigators and more than 300 ongoing research studies aimed at improving the health of and care for our nation's veterans. His leadership has emphasized close partnerships with clinical and policy stakeholders in VA, a focus on translating research into routine evidence-based care in VA healthcare settings, and a dedication to veteran engagement in all we do. He has also been a champion for women veterans research from the start, and we are pleased to announce his recent approval of a 5-year extension of the Women's Health Research Network's efforts to advance women's health research. Dr. Atkins?
Hi, thank you. Is my audio okay?
Yes.
Yes.
Great. Thanks, everybody. It's really a delight to be here to help kick off this conference. Thanks, Becky, for those kind words, but credit really goes to my predecessor, Seth Eisen, who 10 years ago recognized the need to prepare VA research for the growth in the population of women veterans. And he reached out to researchers and to Becky in particular to give birth to the idea that became the Women's Health Research Network. It has now been renewed for, I think, the 3rd time, over which time its scope has steadily grown. It now consists of 3 components: the Women's Health Research Consortium, which plays the role that this conference is playing, which is to identify new areas and gaps in research and develop forums to identify the types of research we need. It also includes the practice-based research network, which includes a growing number of sites interested in enrolling women veterans to support multi-center trials. And then under Allison Hamilton's leadership, a very exciting effort that's more recent, developing multi-level stakeholder engagement. We've been really lucky from the beginning that this partnership has been led by 2 people who really are one of a kind. It made me look up the Latin term sui generis, which really means in a class by themselves, in Becky and in Patty Hayes, the Director of Women's Health on the clinical side. But importantly, they've really built an incredible team of talented people who are really going to be at the forefront of much of this conference. The principle behind the Women's Health Research Network was to build a community of VA researchers and then to let ideas generate from within that community. And that has led to formation of specific work groups of interested people. Jody Caton is a great example of taking an emerging idea and identifying the need to expand on it, and that's led to this conference. The impact of the Women's Health Research Network has really gone beyond women's health. I and HSR&D, recognizing the value of this community building and the strong partnership with clinical partners, have begun trying to replicate this idea with a concept we're calling Consortia of Research. We are now 2 years into it with cores on access, on virtual care, suicide prevention, and chronic pain and opioid use. I must say I'm very glad to see the WHRN take on this issue of reproductive health. My wife is an OBGYN, and I've from the beginning recognized that for this cohort of younger women who are joining the VA after having served in Iraq and Afghanistan, that reproductive health is really a critical part of their health care during their youth and middle ages. And especially important, reproductive health occurs at the intersection of primary care and community care, which is an issue that's gotten increasing attention with the growth of the community care program. I'm delighted to see the work of Kristen Maddox get the attention it deserves. And she has built on her work in maternity care to really build a very successful partnership that we are trying to help grow with the Office of Community Care. It's really critical to know how well we're meeting the needs of our women veterans, what the best way to meet those needs is through a combination of VA and community services, and how to make sure we're coordinating those services across health systems when that's necessary. So I'm not going to be able to stay for the whole conference, but I look forward to dropping in and out for some really interesting sessions, and I'll turn it over to the next speaker. Thanks.
Thank you, David, and for the commitment of HSR&D to women's health research. Now I'd like to introduce Dr. Patricia Hayes, the Chief Officer of the VA Office of Women's Health, and Dr. Amanda Johnson, Director of Reproductive Health for VA, to speak briefly on the importance of research to the care of women veterans' reproductive health care needs.
Thank you, Dr. Yano. This is Amanda Johnson, and I will start this presentation. Are our slides up for this presentation, or are there slides available for this presentation? If not, we'll go ahead and get started speaking. We have a prepared slide set for this presentation. Is it available?
Amanda, you should have control of the slides and be able to move
I
those
do have
forward.
control of the slides. I just don't see our slides in the master set. That's okay. I will go ahead and get started speaking. So again, I want to echo what Dr. Atkins said and really welcome everyone to this very important conference. Today, Patty Hayes and I will briefly discuss the role of research in meeting the reproductive health care needs of women veterans. We'd like to start with echoing the importance of women veterans in the population of users of VHA. Currently, 30% of all new veteran enrollees are women. In fiscal year 2021, 870,000 unique women are enrolled in VA, and the Enrollee Healthcare Project model estimates that the number of unique women enrolled in VHA will exceed 1 million in fiscal year 2027. So it represents a significant portion of the veteran population. what we know about the age distribution of female veterans and female VHA patients really reflects reproductive needs of these patients. We know there are 3 main peaks of ages of women users of VHA. There's one significant peak at age 35, so that would encompass veterans whose reproductive health care needs might reflect contraceptive needs, maternity needs, fertility needs. The next significant peak and the largest peak is age 57 to 62. The reproductive needs of this population would include issues such as pelvic floor disorders, management of menopause, urinary incontinence. And then we have another significant peak age later at 95, where we start to think about reproductive needs of the elderly population, including things, management of postmenopausal bleeding, again, management of menopause, osteoporosis risk prevention. When we think again about the reproductive health needs of women veterans, it's really useful to look at the reproductive lifespan. So really looking at veterans, starting throughout their military deployment, their separation, and then veteran status, and following them throughout their different life course. So that would include menstrual health, contraception, potentially pregnancy and fertility, cervical cancer screening, and then moving into the older population, menopause, osteoporosis, breast cancer screening. And then there are some reproductive health needs that are really relevant across the lifespan. That would include in sexual function, sexually transmitted infection, pelvic floor disorders, including pelvic pain, urinary conditions, and then other gynecologic and specialty care. I am now going to hand over discussion to Dr. Patricia Hayes, Chief Officer of the Office of Women's Health.
Good morning and good afternoon, everyone. Thank you for having us today on the introduction to this research conference. And I have to give a special thank you to David Atkins for his very kind introduction and actually capturing many of the important points as to why research is such a contributing factor in our ability to serve women veterans. We've had a vision for the office from the beginning. And I think it bears repeating because we strive to be a national leader in the provision of healthcare for women veterans, thereby raising the standard of care for all women. And I think it's been particularly gratifying over time that by looking at the ways that research can both lead our work and document our work in serving women veterans, it's been a way in which we have been able to promote methods and types of care, promote whole new ways in raising the standard of care for women across the world. And we really had seen that at times in terms of the work being promoted, not only in US healthcare, but in other countries' healthcare. We strive as an office to be a trusted resource for the field and ensure that the veterans' experiences are timely and high quality, comprehensive, and in a safe environment. And so, of course, research has a role, again, in working to make the quality of our care rise to the standard that we need it to be. We've been working with research before, during, and after kind of a role. We try hard to promote ideas and to support things. We reach out a good bit to have researchers help us do program evaluation, and then obviously there's a lot of offshoot of that creates research framework and helps to kind of go off and multiply in terms of research. And we know that it's important for women because women veterans have unique characteristics compared to the population of all people, all women. It's critical to understand women veterans in order to best serve them, demographics, including the burgeoning group of LGBTQ plus population, where we use the term loosely women, and we're actually working to try and make sure that we are more inclusive in our language so that everyone has a sense of being part of the care that we serve, that we deliver. And we know that research is critical to informing our policy in every area, particularly though in the areas of maternity care, infertility and IVF, contraceptive access and things like copays. How do we compare to fact that there's the Affordable Care Act, that type of information, pelvic pain, pelvic disorders, treatment for pelvic disorders. And because we have such a large health system in the Women's Practice-Based Research Network, you all are perfectly positioned to do this work. And I don't think we knew early on how much this resource of the Practice-Based Research Network was going to be. As we've added more and more sites and been able to do so much more work with the power of having women represented in the many, many research sites. So as a partner in this, we're very excited today to talk about research areas and to continue to brainstorm with you. People have often heard me talk about the economies of intellect. That's why we have these conferences. So I'm excited for us to go forward. Understanding women, veterans, understanding the needs is a critical part that research helps us get to in terms of all of our work with women veterans. So thank you for inviting us. We're going to go ahead and join in with the next speaker, and I'll launch the conference at this point.
Thank you so much, Dr. Hayes and Dr. Johnson, as well as Dr. Yano and Dr. Atkins, for opening the conference with such important words about the importance of this work, the study of reproductive health for veterans, and the valuable context setting. My name is Elizabeth Patton, and along with Dr. Jody Caton, I co-lead the Reproductive Health Research Work Group, and it's our pleasure to welcome you to the rest of our program today. What I want to take the opportunity to do is give a brief and a couple of reminders. Could I have if I could get control of the slides, please.
Dr. Patton, you currently have control of the slides.
I'm just having trouble advancing. Hang on, let's see. Could I ask for some help from the CIDR team, perhaps, to take back control in advance? While we're working out our tech, thank you, and we can go to the next slide, please. I'd like to welcome the audience, and one of the challenges in the virtual space is it's wonderful so many more people can join, but it's also difficult because we don't have some of that same sense of connecting with each other in person. We would love to hear from all of you who are joining us, and if you want to add this into our Q&A box, which should be on your right, where are you joining from, and what is your role or connection to the topic of veteran reproductive health? Let's just get a sense of who's joining us today. So as you're doing that, just navigate over to the chat, put your answers in. We'd love to see them, and I'll just review briefly a couple other points before we get started with our main program. So where are you joining from, and what's your role or connection to the topic of veteran reproductive health? I'll take the next slide, please. So we can already see the breadth and depth. We have people from Florida, from Seattle, from Ann Arbor. Linda Nelsworth, one of my former LPNs and wonderful women's health clinicians back in Ann Arbor. I used to work with you. Students, it's great to see so many people. So today what we're hoping to do is to give a snapshot of the dynamic and growing research field around veteran reproductive health. We'd like to connect research to the needs of the end users, the VA health system, veterans, and their clinicians, and to explore areas for future research directions with a diverse group of stakeholders. Next slide, please. We have a very exciting day planned. We have 3 panels of research presentations. Our first panel will be on reproductive health from epidemiology to implementation. We'll follow that up with VA gynecology across the life course. Then we'll have a 15-minute break. We'll return for our third panel, reproductive mental health from pregnancy to menopause. And then our fourth panel will conclude our day with a dynamic interactive discussion with several key leaders to look at where should we go, what should our next directions be if we're thinking about a research agenda for reproductive health that really meets the needs of women veterans. Next slide, please. As we go through the day, I want to invite all of you who are participating to put your questions and thoughts for speakers in the question and answer box. At the conclusion of each panel, there'll be time for discussion amongst the panelists, and we'll draw many of the questions for that from your questions that you put in the chat. I also want to make a few notes about technical issues. Certainly, virtual conferences have their own special brand of technical challenges. Occasionally, people will note there's a dissociation of sound from the slides. This is often a local bandwidth issue that will fix itself in a few moments. If your audio is not working, if you're using the computer audio, consider going to the ellipsis that may either appear at the bottom of your screen or at the top, depending on where your controls show up, or at the top left where your audio and visual menu are, and choose phone instead of computer, and then choose the phone callback option. You can enter a preferred number and WebEx will call you. You can then put that on speaker and listen to the conference. If you're having bigger struggles, something really just is not working for you, you can certainly note it in the Q&A, but the best bet is to contact the VA help desk. Unfortunately, we don't control some bigger issues in IT. Let me just take a quick peek at the chat and see what else we have here. So we have some program managers, researchers from Alabama, Minneapolis, Los Angeles, Washington. We have women's healthcare coordinators, people specializing in trauma and women's sexual and reproductive health, a really wonderful variety of people joining us. So thank you all so much for taking time from your day. At this time, I would like to introduce our first panel discussant, who's Dr. Amanda Johnson. She's going to moderate our first panel on women, veterans, reproductive health, from epidemiology to implementation, and she'll introduce our speakers and get us started.
Thank you so much, Dr. Patton. I hope everyone can hear me. I saw some feedback that my sound wasn't ideal, so really trying to speak up now. Just very excited to be the discussant for this first panel. It's my pleasure to serve. I'd like to briefly introduce our panelists, who will then present their work. We will save questions for the end of the panel after we've heard all the presentations, but please do add your questions to the Q&A chat box on the right as you listen to each talk, and we will gather them and then have answer questions at the end of all of the presentations. Our first panelist today is Dr. Lisa Caligari, MD, MPH. She is a core investigator for the VA HSR&D Center of Innovation for Veteran-Centered and Value-Driven Care. She is associated with the VA Puget Sound Healthcare System and is an associate professor of obstetrics and gynecology and health systems and population health at the University of Washington. We also are pleased to have Kristen Maddox, PhD, MPH, as one of our panelists. Kristen is the Associate Chief, or excuse me, Dr. Maddox is the Associate Chief of Staff of Research and Education at VA Central Western Massachusetts Healthcare System. She is also the Associate Dean for Veterans Affairs and a professor at the Population and Quantitative Health Sciences at University of Massachusetts Medical School. And finally, we have Dr. Ginny Ryan, who's an MD-MA. Dr. Ryan is a subspecialty reproductive endocrinology and infertility consultant at VA Puget Sound Healthcare System. She's also professor and division chief of reproductive endocrinology and infertility for University of Washington Medical Center, Montlake. Welcome to our panelists. Lisa, Dr. Caligari, I am going to hand it over to you.
Great, thanks so much, Amanda. And let's see if I can get my slides to advance. Great. Well, good morning, everyone, or afternoon, depending on where you are. And thanks for the introduction, Amanda. So as we heard earlier, one of the key objectives of this conference and this panel is really to illustrate how VA researchers in reproductive health are taking insights from epidemiologic research and then using them to design interventions or inform policy to have a downstream impact on veterans' lives and health. And so I am going to share with you all the story of our efforts to do exactly that through our work with the MyPath tool and intervention. So as everyone in this audience is well aware, the numbers of reproductive age VA users who are capable of becoming pregnant is continuing to grow. And epidemiologic data suggests that this population has a high burden of medical and mental health comorbidities that can lead to poor reproductive health outcomes. We also know that most of these veterans will have a need for family planning services at some point to help them achieve the families they desire, which could include contraception to help them defer or delay pregnancy until they're ready, or preconception care, especially if they have chronic conditions, to help them optimize their health and really increase their chances of having a healthy pregnancy. So VA primary care physicians are poised to address these needs, but what we've learned from survey data is that only about 44%, so fewer than half of women veterans who are capable of pregnancy, report that they've discussed their family planning needs with their primary care in the past year. So what's going on here? Well, we know that from research on the provider side that some of the barriers include things like lack of time, which is of course the usual suspect in primary care and often a key barrier. But in addition, patients often don't ask or don't bring up the conversation. And primary care providers who see lower volumes of women veterans may not feel comfortable initiating or having conversations about pregnancy desires or contraception. On the patient side, we've done research that has suggested that women themselves often don't know how to bring it up. They may not feel comfortable bringing it up. They may be concerned that it's not a priority for their PCP. And they bring potentially negative experiences that they've had in the military or in the VA related to experiencing judgment or perhaps not feeling heard. So way back when we started the MyPath project years ago, we asked ourselves whether there was a way that we could leverage technology to help address some of these barriers and really improve the quantity and the quality of family planning discussions that were happening in VA primary care. So that brings me to our innovation part one, which was developing the MyPath tool itself. And based on what we heard from PCPs and providers in general, we wanted to avoid adding another clinical reminder to their plates. And we were interested in exploring patient-facing options that could really work by empowering and activating patients. And so we decided that the data was really strong, favoring the role of patient-facing web-based decision tools to promote shared decision-making and really facilitate high-quality decisions around many health decisions. And we thought that this would be a potentially really promising technology for reproductive decisions, which are highly preference sensitive. And at the time we started MyPath work, there were no existing tools that really looked broadly at the set of decisions around pregnancy timing, pregnancy goals, preconception health, as well as contraception. And so we developed MyPath in conjunction with veterans, PCPs, and those two groups are the key users, and scientific content experts. So MyPath is designed to be used prior to visits by veterans with the goal of, again, helping to empower veterans to bring up topics that are of interest to them and that are important to them, and the goal of really centering veterans' preferences and needs in discussions around their family planning needs. And so MyPath's objectives include to elicit the user's reproductive desires and goals in a respectful manner, to build knowledge and address common misperceptions around fertility, contraception, and then to really facilitate selection of birth control that's aligned with values and preferences. Again, we know it's a very preference-sensitive decision. There often aren't right or wrong answers. And then lastly, to promote patient-centered discussions and shared decision-making. And the tool itself generates a summary which pulls together all of the topics that patients are interested in, the questions they have, their preferences, and that can really be used to guide a clinic visit. So we pilot tested the MyPath tool in 2017, and we recruited 28 veterans prior to introducing the tool in the clinical setting, and then 30 veterans after introducing the tool into 2 women's clinics in the Seattle area. And this slide shows the results from our primary outcome, which was really, were we able to achieve a reproductive needs discussion in the visit. And I will say that everyone who was recruited for the study had expressed before the visit that they had an interest in talking about this. So this wasn't people that just wanted to go in because they had knee pain. This was people that were interested in talking about it. And what you can see from the bar graph is the blue bars are the discussions that happened in the intervention group, and the red in the control group. So veterans who used the MyPath tool before their visit were more likely to have a conversation that really reflected what they wanted to talk about in the visit. We were also interested in looking at pre-post changes within the groups for several patient-centered outcomes, including patients' confidence in their ability to communicate with providers, their family planning knowledge, some measures of decision quality, including decision conflict and values concordance. And what we saw was that the pre-post changes were significant in the intervention group. We also saw some improvements in the control group, but those were not significant in terms of the pre-post comparison. If we look at within group comparisons, we can also see the column on the right with the p-values that the differences were significant or trended towards favoring the intervention. So that leads us to our next innovation part 2. And in the pilot study, we had veterans using the tool on an iPad in the clinic waiting room. And what we realized through the study was that this approach was going to be really hard to scale for a number of reasons. And so if we wanted to use MyPath more broadly, we were going to have a tough time doing it by relying on having there be iPads available in clinics. So given that 97% of women veterans have either a smartphone or access to one, we decided to pivot to focus on using smartphones for veterans to access the MyPath tool. And we connected with the Vet Text program, which is the platform that VA uses to send out text messages as reminders for appointments. And Vet Text can also be used to send out a custom one-way text to a distribution list. And so we went ahead and piloted using text messages to send an invitation and the actual link to the tool to veterans 2 to 3 days before their primary care appointment. And we assessed how well that worked in terms of delivering the tool. And we found that it was an acceptable and feasible way to get the tool into the hands of veterans before their visit in a way that could be scaled. And so this is an example you can see on the right of what the text looks like. And at the bottom, there's the link to the tool. So our next steps are studying the intervention, again, sending the tool via text message prior to primary care visits. And we're conducting a multi-site pragmatic cluster randomized control trial. It's currently underway at 7 women's health PBRN sites. And again, just to call out, again, my appreciation of the Women's Health Practice-Based Research Network and all the efforts that they have done to set that up. I'm an example of leveraging the benefits of that. And this is a cluster randomized trial that is randomized at the provider level. We've recruited 32 providers at this point, and we're starting now to recruit veterans. Our primary outcome continues to be the occurrence of a patient-centered discussion about reproductive health needs. And we are also looking at the patient-centered outcomes I mentioned and some clinical outcomes around contraceptive use patterns, engagement with preconception care services, and unintended pregnancy. And we'll also be looking at treatment effects and heterogeneity of those effects by certain factors that are key, including race, ethnicity. And I want to also mention that we are partnering closely with the Office of Women's Health Services. We've gotten a ton of encouragement and support and really, great intellectual contributions from their office with the hope that if we are able to demonstrate efficacy, that we can implement this more widely in VA. And then I just want to briefly highlight that there's been a lot of interest in using MyPath outside of the VA as well, which has been exciting. And this is a list of, on this slide, some of our partners, institutional partners outside of the VA. Some of the studies that are happening are using MyPath in a similar way to how we're using it in VA. Other studies are adapting it to use in different settings. And I'll just give you one example, which is an NIH R01 grant that we just had funded to adapt MyPath for the postpartum setting for women with substance use disorders at the University of Pittsburgh. So, so that is exciting. And then I'll just finish by saying that none of this work would have been possible without the incredible community of people who have been working with us along this path for many years. And that includes my collaborators and mentors, both within and outside the VA, my amazing team at VA Puget Sound, our funding, our operational partners. I mentioned Amanda, Alicia, Sally, and I'll also say, I know Lori Zephyrin is joining this conference later. She was one of the early supporters, so I just want to make sure I call out Lori as well. And then the Women's Health PBRN, Susan Frayne is obviously a leader and has been a great advocate. And then last but not least, the veterans who helped to really keep us grounded in their perspectives and their voices and their needs through our Veteran Advisory Board. And with that, I will pass it on to Kristen Maddox.
Thank you very much, Dr. Caligari. And now we are ready to hear from Dr. Maddox. Welcome, Dr. Maddox.
Thank you so much, and thank you to Lisa for that amazing presentation. It's always great to hear our colleagues present and see the types of things that they've been doing. So thank you for having me today. I have to say that I emailed Heidi before this and wondered if the camera would be on, so I would have to put on a nice shirt. But fortunately, the camera is not on today, so I think probably we're all just at home in more comfortable clothes than we usually wear. So anyway, it's good to be here. So I'm going to talk a little bit about the study that we've been having for probably the past 5 years or so, called the Center for Maternal and Infant Outcomes, known as COMFORT. I'm trying to advance the slides, and for some reason, would you mind advancing the slides? Because for some reason it's also not advancing for me. Thank you. Okay. The background of this is sort of in around 2013. There really wasn't much known about pregnancy and maternity care for women veterans. At that time, there were a very small number of papers looking at a few aspects of pregnancy or mental health, for example, but there really wasn't much out. This kind of started the journey of just trying to understand more about, pregnancy and maternity care for women veterans. Interestingly, my interest in this kind of arose from the fact that I thought pregnancy care was a really good example of non-VA care, which we used to call fee-basis care back in the days. And so my interest in doing this first kind of arose from trying to understand how women veterans got care coordinated between VA and community obstetrical providers. And so the generation of the study was basically founded in a deeper understanding of trying to understand care coordination, but then sort of over time it evolved to look at other things as well. Next slide. One of the other reasons that we started to do this study is I was also very interested in understanding more about disparities in care, and I was particularly interested in studying racial ethnic disparities in care, but also learning more about variations in care for veterans living in urban and rural areas. For those of you who know me, I'm originally from Montana, and so a lot of my interest arose from just knowing that care in Montana is very different than care in Boston or Los Angeles or places like that. And so I wanted to understand how pregnant veterans access care both in rural and urban areas. So the overarching goals of the study were sort of here below. Some of them I've already talked about, but really the big picture was to kind of understand as many aspects about pregnancy, maternity care, and even a little bit about infant care as we could. Next slide. I will follow up with another great thing that Lisa said, in that this study was designed using the Women's Practice-Based Research Network, and it has been truly incredible to work with the PBRN. One of the things that Becky Yano said, I remember in the early days of starting to work with her, is basically that at any given site, you don't have a lot of women and you have an even smaller number of pregnant veterans. And so the only way you can do studies like this where you are actively working with pregnant veterans is to use a variety of VA study sites. And so by using the Women's Practice-Based Research Network, we were able to use more than 15 VA study sites. And I'll show you a map in just a second so you can see what they all were. But to date, we have enrolled 1,324 pregnant veterans, and we have conducted both baseline and follow-up interviews with those veterans. And so we have an obscene amount of data, actually, for both baseline and follow-up and survey data as well. One of the things I'm particularly pleased about this cohort, though, is that I do think that we have, as much as possible, a racially, ethnically diverse sample in terms of 50% white, 25% white, Black, 21% Asian or Native American. It was very important to me to try to select sites that really demonstrated racial and ethnic diversity. Next slide. So just so you can get a sense of the study sites that we used, I just wanted to point out these sites for a couple of reasons. Number one, every single one of these site leads has been incredible to work with over the past 5 or 6 years. These sites have been amazing, just keeping this study up and moving over the years. And as you can see from the study sites, I tried to include very large urban areas, like Los Angeles, for example, and Dallas, but then also a lot of very small sites, so I could better understand the rural nature of maternity care. So Fargo, Kim Hammer in Fargo, North Dakota has been a great partner. In the later years, I included San Juan, Puerto Rico, because I thought that our sample needed more women, more Hispanic women. So this is just sort of basically the breakdown of enrollment over the past 5 or 6 years. But we greatly exceeded our enrollment numbers that we planned, and so this has been a good diversity in terms of the sample. Next slide. So I'm going to just spend a couple of slides talking about some of the things that we've looked at. I'm not going to go through any particular paper in extensive detail, but I just wanted the people on this call to understand some of the things that we've looked at. And again, my intent in doing this was to understand as many aspects of pregnancy and maternity care as possible. So our first paper that we had come out was just a sort of a baseline understanding of veterans' access to prenatal care and utilization of maternity care coordination, which was the original intent of the grant. So that came out early on. One of the things that I'm most proud of, and she'll be talking later today, is Amy Kroll-DeRosiers, who works with our group, has done substantial work in the area of perinatal depression, and I'm just so proud of her for the work she's done. And so as you can see, she's published a number of papers looking at perinatal depression in this cohort. We've looked at breastfeeding, we've looked at VA health services utilization during pregnancy. One of the papers that I am most excited about that's a recent paper is looking at racial differences in C-section rates among the 15 study sites, which had really interesting and important outcomes, basically showing that women, Black women in particular, had much more significant rates of C-sections compared to white women in areas like Durham, Dallas, Los Angeles, New Orleans. In some of those areas, the rate of C-sections among Black women enrolled in our study, it was about 70% in at least one of the areas. And so that has been a really impactful paper, and I think that is one of the main things that we should be thinking about moving forward. More recently, Susanna Creech has published on intimate partner violence. That was an important paper. I think she found that about 14% of pregnant women had experienced intimate partner violence in the last year. Next slide. And then we have some folks that have been looking at substance abuse during pregnancy, substance use and abuse. So Cass Holzhauer, who's with our team, looked at prenatal stress and alcohol use. Amy Kroll-DeRosiers, along with Lori Bastian and some other folks at VA Connecticut, looked at quitting smoking during pregnancy. One of the papers that's currently under review is looking at racial differences in cardiovascular risk factors. Again, that's a Durham team. Rebecca Lemson and Karen Goldstein and some other folks. Susanna Creech has a great paper under review right now that's looking specifically at the role of MST on maternal and infant bonding, which I think is a really important area to be thinking more about going forward, because quite honestly, we don't really know much, if anything, about these babies. The VA does in fact provide 7 days of care for infants after following delivery, but we don't really know much about what kind of happens to those infants afterwards. And so I think that this paper really trying to understand, maternal infant bonding and the impact of MST is such an important paper. We have a paper under review that's looking specifically at COVID-19 vaccine hesitancy among pregnant veterans. That paper also seems to suggest that pregnant veterans also may have hesitancy about childhood vaccinations in general, along with COVID-19. So I think that's an important thing to look at more carefully in the future. Next slide, please. Kate Sheehan, also out of Durham, has a paper under review looking at sufficiency of information received during pregnancy. We're looking at the impact of past trauma, multiple traumas on kind of managing COVID. With that work, I worked closely with Kate Iverson and Dawn Vogt in Boston to help understand that. So I think that's going to be some good work. Rebecca Kinney has a paper under review looking specifically at newborn outcomes, and Laurel Copeland has been looking at prescription medication use among perinatal veterans. Next slide. So I think that, that kind of summarizes the broad areas that we've looked at. But if I'm thinking about, some of the important things to do, I think that we have scratched the surface in terms of racial ethnic disparities in maternal and infant outcomes. I think that there are so many more important directions to take, and I'm saying this to this group of people on the call because I think that all of us together need to be looking more carefully at this. I think the impact of social determinants of health on pregnant veterans. I mean, we need to understand more about other types of things these pregnant veterans are having to deal with. Housing, food assistance, childcare, employment. All of that is important, and I think that we're just scratching the surface in terms of understanding that. I think it's incredibly important, and we're partnering with the Office of Community Care to better understand the quality of non-VA obstetrical care. One of the things that we haven't done well in the VA at all is we haven't paid a lot of attention to the quality of non-VA care. It's been something we've been thinking about over the years, and I have to say the Office of Community Care is now starting to think more carefully about those types of things, and that's great. But the quality of non-VA obstetrical care is one of the things that we need to be looking more carefully at in the future. Next slide. So in terms of the clinical and policy implications impact, I do think that things have changed over time, but in our study, we did find that a pretty substantial number of pregnant veterans were not accepting the COVID vaccine. Granted, we collected this information several months ago, so it could be with all of the recent importance of getting the COVID vaccine. It could be that more pregnant women are getting the COVID vaccine, but I think it's important to continue to watch that and put out positive messages about that. I mentioned the importance of examining access to high quality obstetrical care. These contracts with Optum and TriWest are relatively new. They're still developing their networks. And so I think that we need to continue to understand what kind of care women are getting in the community. One of my areas of interest is understanding network adequacy, which is really the ability of women to get care from community providers that is somewhat geographically close to them. So again, my heart is in Montana and Wyoming, and thinking about women, in parts of the country that access is hard to get. And so, I think that's important to continue to study. And as I mentioned earlier, I think social determinants are key. We can't really understand outcomes among pregnant veterans if we don't understand a little bit more about the social determinants that impact those women. Next slide. Okay, that was all. So thank you so much for taking the time to listen to this presentation, and I look forward to your questions later in the presentation. And I think Jenny Ryan is up next.
That's right. Thank you very much, Dr. Maddox. For our final presentation, we'll hear from Dr. Ryan.
Good morning or afternoon. Can people hear me?
Yes.
We can hear you.
Excellent, wonderful. Thank you so much. Well, it's great to be here and amongst such accomplished colleagues. I'm really honored to be here. I've had the pleasure of working at the VA for the last 7 or 8 years. First at the Iowa City VA, where I worked both clinically and with an IIR through Cadre, their coin. And then now I've just moved about a year ago to the Puget Sound VA, where I'm providing some clinical care, and we're continuing to work on the data from the IIR. So I'm excited to talk with everybody today a little bit about infertility, prevalence and associations that we found some results from our study. I'm not sure if I can do the slides, so if others can.
Dr. Ryan, you have to click on the slide itself.
Got it. Great. Perfect. All right. So others have discussed this already today, but we think there are now 2 million or more women veterans out there, and the age distribution is trimodal. And you can kind of see the proportion here on this slide of women of reproductive age in the US. And they're also the fastest growing subgroup of veterans. So clearly it's important for us all to best understand issues with reproductive health care. And as we know, and has been represented here, the Women Veterans Healthcare Program considers reproductive health as one of its 6 strategic priorities. And yet some studies in the past have shown that veterans experience gender discrimination and knowledge gaps in their care. And they specifically called out inadequate infertility coverage, potentially due to the system being set up originally for men and not still set up very well for couples or family type care. So we, as Dr. Maddox was saying too, back in 2013-14, as we were looking at what data were out there for infertility, we found that as is the case out there in the broader community, infertility has been underrepresented as a focus of research in the veteran population. That's been improving in recent years, but certainly back at that time, that was the case. Studies would just be looking at sort of diagnostic codes and show something like a 1% prevalence of infertility in the veteran population, which, obviously we knew that wasn't the case, and anybody working clinically could identify that as well. I also want to point out that while infertility broadly is underrepresented as a focus of research, infertility in men is also, chronically underrepresented in the world of infertility as well. All right. So we know it out in the broader community that the inability for a couple to become pregnant is quite common, about 10 to 15% perhaps of couples. And we also know that US military service members, as Dr. Hayes and others have brought up, have unique physical and mental health challenges that certainly may be harmful to fertility. And that has been shown in broader community work that is continuing. Things like sexual assault, blast injuries that cause genitourinary trauma and traumatic brain injury, chemical exposures, and post-traumatic stress disorder. But how common infertility is accurately among US veterans, and then the relationship between infertility and these experiences that service members may have in their military service is not still well understood. So we did some pilot work in Iowa on 1,000 women veterans, and it was not focused on infertility, but there was a question within there that queried that. And we saw some associations there between lifetime sexual assault, again, in these female veterans, and an increased risk of lifetime infertility. Again, the prevalence measure was not one that's well validated, but it did, give us pause. We also, interestingly, had some data suggesting that those women experiencing a completed rape may actually delay or forego childbearing.
So we felt that these were some important data, and also we felt the lack of an understanding of prevalence was, made it difficult as we're thinking about providing our military service people with the best preventive and therapeutic care for their fertility needs. So to that end, this is just a graphic showing our IIR approach. It was a sequential mixed method study that you can see here, maybe it's a little bit small, but our first specific aim was really to look very carefully at prevalence in a cross-sectional population of a national population of reproductive age veterans, men and women. And we did that using multiple measures and using some expertise in the community to help us with that. And then we wanted to look at associations, again, with some of these factors that we think our veterans have been at increased risk of exposure to. So in total, we ended up interviewing 3,018 men and women veterans from across the country, all aged 20 to 45. They'd all separated from their military service, either active duty or Reserve National Guard in the previous 10 years. Our study was very inclusive. We made special efforts to not exclude based on marital status, sexual orientation, gender identity, etc. And so was very inclusive, and we felt that was vital given that past large epidemiologic studies have excluded on those measures. So our total interview was 1 hour and 27 minutes, and it was remarkable actually how willing veterans were to take part in such a long study talking about such difficult exposures that they may have had. We also then, as part of our sequential, this mixed methods approach, we did purposefully sample 60 of these participants to talk further in a semi-structured way about their family building goals and how their military service may have impacted those goals. So I'll just be presenting some of the data that we have so far. These have actually still only been published in abstract form. So you can't yet find them out there in the literature. But these are some of our early findings. Again, we used multiple prevalence measures. And it's important to kind of understand the denominators for these different prevalence measures. But you can see on the left there that if we're just looking at unprotected intercourse for 12 months or more without conceiving, we saw a large percentage of our male and female veteran population who self-reported infertility using that measure. The next set of bars shows trying to conceive, so with intent to conceive for 12 or more months. And that shows numbers that are still higher than what we have seen in other studies in the community, but certainly closer to those prevalence numbers. And then if you look at the third set of bars there, again, women on the left, men on the right, for ever diagnosed, this would be if the veteran and or a previous or current partner had ever been diagnosed by a medical professional. And then finally, the bars on the right, you can see numbers for ever treated for infertility. So again, you can see, regardless of the definition applied, it seems that lifetime infertility prevalence is high among US veterans compared to the general population. So our range, as you could see, of 17 to 46% is higher than what we typically see in the general population of 7 to 16%. But it's always important to, again, look at the denominator and how each of these epidemiologic studies have been carried out. Again, incorporating the intention to conceive clearly reduced the magnitude of the prevalence. And what we're also seeing is that there's a large gap between those who are identified in the study as infertile and those who received infertility care. And we do have data on where that infertility care was received, as a number of other details that we have, points of data that we have yet to really drill down into. And in starting to look at the key findings of our infertility prevalence and associations, one thing that's not on this chart is that, interestingly, and to the point of underrepresented populations within the VA, we did find that regardless of infertility measure, there were actually few differences by race and ethnicity, which does contrast with other studies in the broader population. You can see here that number and length of deployments, those data were associated a little bit variably between men and women, but were both associated with infertility. And very interestingly, and we've seen this throughout, looking at all of these associations in our various sub-analyses of the data, that PTSD just is persistently associated with infertility in men and women and across multiple prevalence measures. We also saw that in women, depression was associated, and that both men and women who reported dissatisfaction with sexual function were also seen to have a higher incidence of infertility. So other key findings that sort of re-emphasize the concerning epidemic of sexual assault. We did see a majority of women that we interviewed of these participants did report a lifetime history of attempted or completed sexual assault. The highest risk time for women was actually in military. And 12% of men that we interviewed also reported an attempted or completed sexual assault. Interestingly, the highest risk time for these men was in childhood. When we've started to look at these lifetime sexual assault data and sexual assault in military data, we are finding that these are associated in women with a diagnosis of infertility, but not with other infertility measures like time to pregnancy. And there haven't been seen to be any significant associations with men. We had a whole module of questions on environmental exposures, and we are starting to drill down into those data. And we're seeing so far that veterans exposed to PCBs and sulfur fires are more likely to meet the definition of infertility. We're finding that a vast majority of our veterans report some kind of exposure to potentially toxic chemicals. And so, a good deal of those veterans who we spoke with do express a concern about the impact of those environmental exposures on their reproductive health. So in sum, we have a long way to go to even fully understand these associations, but even within our own data to drill down at these associations and the interactions that there may be within it. But we're starting to see that veterans may represent a unique population at high risk of infertility. And thus there's likely an unmet need for infertility care in the VA. I think those who treat women and men who providers who consider fertility care as an important aspect of their overall health and reproductive health will tell you that veterans still, despite the hard work of the Office of Women's Health, don't understand that there is good care available through the VA for basic fertility evaluation and treatment short of IVF. And we could talk more about limitations on the IVF care at this point, but there's still a gap between an understanding of what's available, with some providers and with many veterans themselves. As Dr. Hayes mentioned earlier, it's also important, I think it's a great opportunity in studying our veteran population that we can understand more about the risks of these experiences, traumas, and exposures to reproductive health in the broader community as well. And again, I think it's important that we continue to better understand what the pathophysiology is behind these associations. So that's it for my slides. Thanks again for the opportunity. And I should take the opportunity, of course, to thank everybody at Cadre in Iowa City, who, especially Drs. Mangling and Sadler, and our collaborators outside the VA, Drs. Torner and Toma and Stern, who've been so very important in developing this project and in continuing the evaluation and analysis. Also, as mentioned previously, Dr. Christie and Dr. Zephyrin have been great supporters of this work and great partners, as I've also gotten to work with them more on a programmatic standpoint, which has been great. And yes, I'm amazed again by the veterans who took part in this study, their willingness to share some of these really intimate details and their trauma histories. And our interviewers also, just amazing work and very difficult subject. So I will pass it back. Thanks, everybody.
Wonderful. Well, thank you so much. Thank you to all of you for these excellent overviews of your important work. It's just been so exciting to listen to them. We have about, looks like about almost 10 minutes to do a little bit of question and answer. I do want to encourage attendees to put their questions into the Q&A box that should be on the right of your screen. Go ahead and put those questions in. But I will go ahead and get started by asking, and I'll start with Dr. Caligari. Can you talk about, just briefly, how you see MyPath addressing disparities in reproductive health, either now or in the future?
Thank you so much for that question, Amanda. And I think it's an incredibly important one. And we really are trying to have an equity lens for all of this work. I will say that so Patty Hayes mentioned really thinking about and considering the needs of our LGBT veterans. And I want to just acknowledge that oftentimes populations like cisgender lesbian women or trans men who are capable of pregnancy are often left out of a lot of this reproductive health research that we do. And so we made a concerted effort within the MyPath study to make sure that we're actually including everyone, and we have sub-analyses for people who are, quote, at risk of unintended pregnancy, but that we also acknowledge that people want to build their families in other communities and really need to engage with providers around services related to preconception health, again, when they have chronic conditions, or to fertility in general, and that this can be sort of an entree into having conversations about fertility more broadly. So I wanted to highlight that we've been really cognizant of doing that. We also are very much interested in understanding if and how this intervention potentially impacts communities differently, marginalized communities. And I mentioned doing things like looking at heterogeneity, the effect by race and ethnicity. And I think that's a really important, a super important area. We know that services and counseling is often perceived as lower quality in marginalized populations. And so we want to be careful not to be just improving quality without having attention to equity. And so we're going to start with, what we're doing in the trial, looking at heterogeneity of effects, and then we're going to really hone in on making sure that, again, we're not just lifting everyone, we're closing important gaps.
Excellent, thank you. I really appreciate that answer. And I did notice a common theme across all the presentations about sort of this really important emphasis on equity for potentially marginalized populations, whether that be the LGBTQ plus community, racial and ethnic disparities, just lots of important focus there. That gets me to Dr. Maddox. Dr. Maddox, in the interviews that you've done, who have been the most interesting or impactful pregnant veterans you've spoken to?
Oh, well, I have to admit I have a very soft spot for women in New Orleans. I hope our New Orleans partners are on this call. Pregnant women in New Orleans have really experienced so much. In some of the interviews we've done there, a good number of them were directly involved in Hurricane Katrina, maybe as obviously as younger women. But it really has you know, the stories that they've told about sort of living through Hurricane Katrina, the trauma with that, and then, you know, kind of moving on in their lives and, you know, experiencing, you know, problems with housing, problems with trying to get a job, you know, being a single parent, like just all of these things on top of each other have really been incredibly traumatic. And so I think that it is the women of New Orleans, the pregnant women of New Orleans, that has really given me thought about what additional services or supports the VA can give to further support these women, because I think that these, you know, that these stories are just so impactful. And I would say another population is the women, many of the women in Durham we spoke with, who, you know, a lot of women across the country got sort of hung up in the contract change between, you know, what used to be TriWest and HealthNet and then moving on to different contracts. And so, you know, we're still talking to women who have to drive an obscenely far distance to get to, you know, obstetrical care and, you know, things like that. And so I think those are the things that I'm thinking about in terms of, you know, the women that have been impactful. And it makes me think about, okay, what can we do in the future with research that's going to better understand some of these situations and conditions?
Thank you, Dr. Maddox. I think that's great. And I think you really highlight sort of those pieces that we sometimes don't think about when we think about maternity care, things like housing, employment, transportation, all of those pieces that really are essential for sort of 360-degree wraparound support and care. And last but not least, I'd like to direct a question to Dr. Ryan. Dr. Ryan, thank you for your presentation. For you, I'd like to ask sort of what do you see from your perspective are the most important areas for next research steps for infertility among veterans?
Thanks for that question. That's the $1 million question. You know, I think we have so much data to continue to look through to try to kind of understand some of the associations that we've seen in these relatively high rates of infertility. But I'm really anxious to again think about the access issue because I experienced that working clinically at the VA. It's a hard enough thing to do to get access to everybody who needs it. For out in the community, but then to navigate the system because most infertility care is out in the community. So to navigate the system for veterans is extremely difficult and onerous. And so I'm really anxious to get to the point of thinking about implementation and perhaps working with Dr. Caligari and targeting populations to get to that point. But I think it'll be really important to drill down on these associations because, for example, as those working with, again, reproductive healthcare at the VA know about the IVF coverage and the fact that that's limited to veterans who have service-connected disabilities associated with their infertility. I think that I'm anxious to get that data out there and to really understand, who are these people who can qualify for this care, because we are seeing these associations between their service-connected disabilities and their fertility challenges. So I think those are the two routes I'm really anxious to continue to work on. But there's lots of opportunity in this arena.
Absolutely. I completely agree with you. Thank you so much to each of you. I wish we had more time to continue the discussion, but I am going to hand the meeting back over to Dr. Patton.
Thank you so much to our first panel. That was a wonderful start. Just a quick reminder also to our audience, please enter any questions you have for the panelists and the discussant into the Q&A chat box, and we are moderating that as we go. I'd like to now introduce Dr. Alicia Christie. Dr. Christie is the Deputy Director of Reproductive Health for the VA. She'll be the discussant for our next panel, VA Gynecology Across the Life course. So I'll hand it back to Dr. Christie to introduce our speakers and get us started.
Thank you so much, Dr. Patton. Can you hear me clearly? It's
Yes,
my
we
pleasure.
can hear you.
Thank you. It's my pleasure to introduce the next panelist. Dr. Best is a board-certified general internist and women's health provider at VA Puget Sound, where she's also the deputy chief of the general medicine service line. She directs the data and analytics group for the HIV, hepatitis, and related conditions program office, and has published widely in the areas of viral hepatitis, HIV pre-exposure prophylaxis, and sexually transmitted infections. She is an associate professor of medicine, Division of General Internal Medicine at the University of Washington, and an affiliate investigator with the VA HSR&D Center of Innovation, a veteran-centered and value-driven care at VA Puget Sound Healthcare System. Dr. Danan is a general internist and health service researcher at the Minneapolis VA Center for Care Delivery and Outcomes Research. Her current research is funded by an AHRQ PCORI K-12 award and focuses on developing and implementing trauma-sensitive, patient-centered primary and preventive healthcare practices for women who have experienced sexual assault. Dr. Danan currently serves as the Minneapolis site lead for the VA Women's Health Practice-Based Research Network. She is co-director of the Minneapolis VA Advanced Fellowship in Health Services Research and is an assistant professor of medicine at the University of Minnesota. Dr. Caton is an epidemiologist and health services researcher, a core investigator at the VA Puget Sound HSR&D Center of Innovation for Veteran-Centered and Value-Driven Care, and a research assistant professor in the University of Washington Department of Health Systems and Population Health. Dr. Caton recently completed an HSR&D Career Development Award and is the co-PI of an HSR&D IIR focused on equity of VA gynecology care for uterine fibroids. Her research focuses on reproductive and sexual health and health equity. She co-leads the VA Reproductive Health Work Group and conducts research in partnership with the VA Office of Women's Health Services and VA Office of Health Equity. We will hear about the research of all of our panelists. Our first speaker will be Dr. Best.
Thank you for the introduction. Let's see, how do I advance this slide? Let's give it a try. Perfect, okay. It's such an honor to be speaking here today. I'm gonna be talking about chlamydia and gonorrhea testing and infection in women veterans. And this work was completed through my role with the HIV, hepatitis, and related conditions program office. Okay, so a few words of background just about chlamydia and gonorrhea in the United States as a whole before I get into some of the results in VA women. So the last year that the CDC produced case rates for chlamydia and gonorrhea was in 2018. And in that year in the United States, chlamydia totaled the highest number ever reported, representing almost a 20% increase since the last batch of CDC data from 2014. And it totaled 1.8 million US cases. Gonorrhea is similar, but even more dramatic. The highest number ever reported since 1991, representing a 63% increase since 2014, and over 500,000 US cases. So the data I'm about to share with you from the VA is kind of against the backdrop of ongoing trends in the US as a whole. So why are we particularly interested in chlamydia and gonorrhea in women? So I don't need to tell this audience, but really these conditions disproportionately impact women. There's the risk of HIV acquisition, which is dramatically higher in people with a concurrent chlamydia or gonorrhea. There are important gender-specific disease sequelae like pelvic inflammatory disease, infertility, chronic pelvic pain, and ectopic pregnancy. And finally, there's a risk of vertical transmission during pregnancy. So for this reason, the CDC recommends annual screening for sexually active women under age 25 and everyone with risk factors. So interestingly, there's very little data within the VA about GC and chlamydia testing and infections in women. So my group set out to analyze trends in testing and infection in all women veterans served by the VA between 2009 and 2019. And to do this, we looked at each year at all women who received VA healthcare in that particular year. To define chlamydia and gonorrhea, we used the VA's really excellent electronic medical record data for lab testing. We looked at GU, rectal, and throat specimens, and we defined new cases as a positive result, separated by at least 30 days from the last positive result to avoid double counting when people get perhaps tested, a few days after the last test. So we're really looking for separate cases. The biggest limitation of this case definition is that we only have lab data from within the VA. So this does not include chlamydia or gonorrhea tests that were performed, at another healthcare institution or at the health department, etc. Just VA-related results. So what we found was that chlamydia and gonorrhea testing over time gradually trended up from 2009 to 2019 in both men and women. So what you'll see here, just to orient you to this plot, the circles are representing women, and up on the top set of lines, you'll see that there's a gradual upward trend in tests per 100,000 over time, with the peak at 2019. And most important of all, the CDC and now actually USPSTF recommendation for all women under age 25 to receive testing. The VA as a system in 2019 tested 22.6% of our women veterans under age 25. If you look over time at cases, there are also some very interesting trends. So again, the line at the top of the plot shows chlamydia cases per 100,000 in women, and you'll see overall an upward trend similar to the US as a whole, where we are seeing the highest numbers in 2018 and 2019. And for gonorrhea, you'll see the green circles and lines. There was sort of a downward trend until about 2014, 2015. And we've been trending upwards steadily since that time, with the peak at 2019. So let's look a little closer at gonorrhea and chlamydia cases in women as of 2019, our most recent year. As a system, VA had 1,303 cases of chlamydia and 331 cases of gonorrhea in women, out of 52,000 or so tests in women. The total incidence for chlamydia per 100,000 women was 222, and for gonorrhea it was 56. The rate really goes up dramatically in younger women, where the incidence of chlamydia in women ages 18 to 24, which is our youngest age group, was 2,050, and for gonorrhea 282. So really striking trends amongst our younger women, again, who are only tested 22.6% as of 2019. So we looked a little closer at groups of women veterans with the highest incidence. Again, this is correlational data, but there do seem to be higher incidence, of course, in younger women for chlamydia, women living in urban areas, women living in the South Atlantic region, women with comorbid HIV infection, and Black or multiracial women. For gonorrhea, we see much higher rates in younger women, those with HIV, or Black or multiracial women. This is similar to trends in the US as a whole, and definitely seems to bear out in VA data as well. So key findings of this work The takeaways are that chlamydia and gonorrhea incidents are substantially increased between 2009 and 2019 among women veterans. And our overall screening rates among women, the youngest age group who are at the highest risk, remain very low. So what are some of the clinical and policy implications and impact of this work? Well, I think the thing that jumps out to me is just how much we are underusing GC and chlamydia testing, especially in our younger and most at-risk women. This has been little studied, but there are definitely opportunities and a need to develop a cohesive strategy for improving our screening rates. So although, the data that I just shared can't tell us what the strategy should be, a few ideas might include improving our training of providers to make sure that all providers who serve women veterans know the guidance for annual testing in younger women and are able to offer testing in evidence-supported ways. We also need to improve our access to testing. So I didn't show this data, but testing rates are highest in women who see women's health specialists like gynecologists or women who are served in women's health clinics. But we have to expand testing so that anywhere a woman receives care, whether it's a specialty clinic, mental health clinic, or maybe it's even home-based testing, that we get testing into the normal medical practice and is offered in as many places as possible. Finally, there are likely opportunities to systematize screening for younger women so that it's offered routinely and is just part of regular medical care. I think for me, the biggest gap in the VA's data resources include the absence of data on sexual risk behavior or sexual orientation or gender identity status. If this data were available, we might be able to better outreach or to focus our testing on folks who are at highest risk. But right now, there's very little to no data available for this information. And then there's tons of future study ideas. There's so many unexplored and important topics to take a look at within this space, particularly what are the sequelae of GC and chlamydia infection in women? What about access to HIV pre-exposure prophylaxis? This is of great interest to my program office, and every single one of the women who has an STI is also at risk for HIV. So making sure that we get PrEP into the hands of women is increasingly and critically important. And then finally, what's the role of stigma? The VA isn't always the easiest place for women to receive healthcare. And how can we remove barriers? How can we, again, make STI screening and testing a part of everyday care in all settings where it's needed? Last but not least, I want to offer my gratitude to the HHRC program office, our collaborators, and the team of fantastic analysts I work with who produce this data. So I've listed those folks here. Thank you, and I'll pass it back to the moderator.
Thank you, Dr. Best. And now we'll hear from Dr. Danan.
Okay, thank you so much for this opportunity to talk about cervical cancer screening in the VA. I think this is a really important topic because screening for cervical cancer is such a core part of women's primary care. And 88%, so almost 90% of women veterans who use the VA are under age 65, which means the majority of them are eligible for cervical cancer screening. So today I'm going to do just a short overview about how we can approach screening and cervical cancer prevention, what we can learn from VA research that's been done to date by a variety of really wonderful VA investigators, and a little bit of work that I have been part of myself, and then talk about how we can move forward to prevent cervical cancer for our veterans. So I'll apologize in advance for the lack of animation in my slides. Apparently, animation in WebEx goes the way of childcare in a pandemic, which is that it just disappears. So they're a little busy, and I'll try to lead you through them. So cervical cancer, as we know, is caused by the human papillomavirus. There are hundreds of subtypes of human papillomavirus and over a dozen that cause cancer. It's a pretty ubiquitous virus, so just about everybody who's sexually active in their lifetimes will become exposed to it. And for the most part, your body will clear the virus. Your own immune system clears it, usually within a year or two. If the virus is not cleared by the immune system, it can settle into the cells on the surface of the cervix and cause precancerous changes that over time can progress to cancer. And they progress relatively slowly, so it can take years and even decades for an HPV infection to progress to precancer and then cancer. And for this reason, cervical cancer is really an ideal cancer for screening. The surface of the cervix is accessible through the vagina, and the progress from infection to cancer is slow. So cervical cancer screening has really been an undeniable public health success story over the last few decades. By implementing widespread screening, the rates of cancer cases and deaths have dropped dramatically. But there's still over 14,000 new cervical cancer cases this year and over 4,000 deaths. So we can think about risk factors for cervical cancer first by starting with that ubiquitous HPV virus. By preventing ever getting infected with the virus, you can prevent most of your risk for cervical cancer, and that can be done through immunization. Immunization should be done before women become sexually active, so in their preteen years is when it's recommended. But we know that HPV immunization rates in the US overall are relatively low. So once you've been infected with the HPV virus, the next risk factors are those that can affect the rate from with which the precancerous lesions turn into cancer and the rate with which your body's immune system is able to clear the virus. So being immunosuppressed or immunocompromised by either an HIV infection, immunosuppressants taken for organ transplantation or taken for a rheumatologic condition like lupus can all increase your risk for your body not being able to clear the HPV virus and or the progression being sped up. And similarly, cigarette smoking is known to speed up that progression from precancer to cancer. But in the end, most cases, new cases of cervical cancer occur in women who have never been screened for cancer, for cervical cancer. And this is because, cervical cancer screening is so effective that even if you have these other risk factors, even if you've been infected by HPV, we can usually catch the precancerous lesions and treat them quickly enough if we do screening. So who is not getting adequately screened? Well, in the US, it's primarily women who are uninsured or have no usual source of care, those who live in rural areas, older women, those who have lower health literacy or education rates, women who have female sexual partners, transgender persons, and then women with severe mental illness or disabilities are screened at lower rates, probably due to provider assumptions about their sexual behavior. And then women with a history of sexual assault seem to have higher rates of cervical cancer. And some data indicates that women who have been sexually assaulted during childhood or have experienced intimate partner violence may be less likely to get screened. And then the last piece here that's important to think about, looking at the pie chart at the bottom, is that even once you've been screened, there has to be adequate follow-up for an abnormal test. So among women who were insured and had a regular source of care when they were diagnosed with cervical cancer, about 13% of those cervical cancer cases seem to be due to a failure to follow up with an abnormal Pap test. So abnormal tests must be followed up with referral to specialty care and appropriate treatment. So in the VA, cervical cancer screening research has proceeded from a number of different directions and using various data sources. There's research that has looked at risk factors for cervical cancer, which can be done with either CDW or corporate data warehouse data. There's research done to look at actual screening completion rates, and this is a complicated thing to look at. You get different results if you look at CDW versus something like EPRP or quality metric dashboards that do more of a manual chart review. There's research looking at patient results notification and follow-up of abnormal tests. In fact, the Office of the Inspector General focused on this in their CHIP inspections last year. We can ask women about their experiences with screening and perspectives. So some of the most interesting research I've seen in the VA has used surveys and focus groups. And then finally, we can do clinical trials or implementation studies. So I'll go briefly through some of the key findings. At the system level, there's variation in screening and follow-up. The average screening rate across all VA facilities is 85%, but this varies between facilities with a low of about 72%, and overall falls short of the Healthy People 2020 goal of 93%. We've seen that women who see a women's health provider are more likely to have been screened in the last 3 years, but a quarter of women veterans still receive primary care from a non-women's health provider. One study looked at which facility features predict screening completion and found that something called what they called clinical support arrangements, and this was things like how many treatment rooms, what equipment, workstations, and space you have in your clinic, were more like, facilities that had more of those were more likely to screen patients regularly. And then finally, I mentioned that VA OIG inspection. They looked at 42 sites to see how many were compliant with follow-up requirements that the VA has for timely notification and tracking of abnormal test results, and found that nearly half of VA sites were non-compliant with those requirements. At the individual level, there's research that shows that women veterans have high risk factors for developing cervical cancer. So 1 in 4 women veterans smoke cigarettes, and this is a higher rate than male veterans and non-veteran or civilian women. About 3/4 of women veterans who come to the VA arrive not vaccinated for HPV, and those that have been vaccinated primarily got vaccinated during their military service. So vaccination in that preteen age range is pretty low in this group. About 1/4 of women veterans live in rural areas where they may be farther from a provider and less likely to get screened. And then finally, older women veterans are less likely to have been screened than their younger counterparts. So compared to women veterans in their 20s, women veterans in their 50s and early 60s are significantly less likely to have had a Pap test in the last 3 years. Looking briefly at some of the data related to sexual assault, which is where my research has been, like other presentations today, we found that about 58.7% of women veterans reported that they'd experienced sexual assault in their lifetime. And that's in a survey of over 1,000 women veterans at 12 VAs in 9 states. We know that women veterans with a history of lifetime sexual assault have higher rates of having an abnormal Pap test in the past. And we found, as did others, that they had higher rates of experiencing anxiety, distress, and discomfort related to pelvic exams. Almost half of them reported that this was moderate to high. Dr. Whiteloff found that women who'd experienced lifetime sexual assault and developed PTSD had the highest rates of maladaptive beliefs that pelvic exams are unnecessary or unsafe. And we found predictably that women who'd experienced sexual assault were about twice as likely than women who had never experienced sexual assault to report that they'd ever delayed a Pap test or a gynecologic exam due to distress. Now, parenthetically at the bottom, I'll note that there's no significant difference in Pap test completion rate, either in Dr. Whiteloff's work looking at depression or PTSD, or in our work looking at lifetime sexual assault. And the reasons for that are complex. But we do find that in self-report, women tell us that their exams are more uncomfortable and that they're more likely to delay them or put them off. So you can conclude that there's both individual and system level risk factors for developing cervical cancer, for inadequate screening, and for inadequate follow-up with abnormal results among women veterans. Experiences may vary based on women's personal trauma histories, but that overall screening rates in the VA are pretty high. And given that rates are pretty high, the policy implications can be complicated. Some would say that if it's not broke, don't try to fix it. But I think that there's a lot of room for work here when it comes to smoking cessation and HPV vaccination, and that if we can include those into the data that's available for providers, kind of at a snapshot, we might be able to make more progress on those. Those clinical facility features like having adequate space and time and having access to designated women's health providers both seem to be associated with increased screening. I think that there's room for more intervention research on trauma-sensitive care and novel screening methods like self-collected HPV testing. And finally, I think that we need to do additional work using evidence-based care models for follow-up with abnormal test results. So I know I'm over my time, but I look forward to your questions and want to thank all of my mentors and collaborators.
Thank you, Dr. Denon. We'll now hear from Dr. Caton.
All right, thank you everyone. And it's a real pleasure today to be able to share our work on uterine fibroids and racial inequities in uterine fibroid care within the VA. I would be remiss if I began this talk without first acknowledging my co-PI collaborator, Dr. Lisa Caligari. Additionally, whenever we share this research and these findings, we find it really important to note our own positionality as white women who are non-veterans conducting research on racial disparities among women veterans, with whom we do not necessarily share a number of critical lived experiences. See if I can advance this. All right, so what are uterine fibroids? Uterine fibroids are benign growths that occur on the uterus. They are extremely common, and estimates indicate that in the US, by age 50, approximately 70% of white women and 85% of Black women will have developed uterine fibroids. Importantly, not all are symptomatic, but about 30% of these individuals will report symptoms. And while we refer to uterine fibroids as a benign gynecologic condition, they are far from benign. Does this sound better? And can produce very severe negative impacts on health, functioning, and quality of life. Additionally, fibroids are estimated to account for about $34 billion in annual healthcare costs in the US, as well as about a third of the hysterectomies annually. Treatment decision-making is complex, particularly as we now have additional options for treatment that do not involve removal of the uterus. And so the decision-making has to include both patients' preferences and fertility desires and values, as well as the severity of the condition and their symptoms, as well and clinician skill and the capacity at a facility where they are receiving treatment. Notably, if surgical treatment is indicated, minimally invasive approaches are preferred, as these are associated with lower complication rates and shorter recovery times. There are well-established racial inequities in uterine fibroids. Specifically in the US, Black women are more likely than white women to have uterine fibroids. They will tend to have larger and more numerous fibroids and are more likely to undergo hysterectomy for this condition. Additionally, when they undergo surgery for uterine fibroids, Black women are more likely than white women to have an open abdominal versus the preferred minimally invasive approach. And regardless of approach, they are more likely to experience complications from surgery. Now, I think it's important at this point to recognize and remind everyone that race is a social construct, and that therefore these racial inequities that we observe are actually downstream consequences of racism. So to summarize our approach for the results that I'm going to show today, Dr. Caligari and myself constructed a retrospective cohort using VA administrative data. We identified either Black or white race via the VA corporate data warehouse, and then used ICD-9s to identify those who are undergoing hysterectomy for uterine fibroids, as well as to identify the surgical mode defined as either minimally invasive or abdominal. And minimally invasive techniques include laparoscopic vaginal as well as robotic-assisted techniques. Further, because many of the characteristics that will drive surgical decision-making are not routinely available in administrative data, we conducted chart abstraction among a subset of 700 veterans. And this data that we collected included parity, surgical history, and while we couldn't get a systematic estimate for number and size of uterine fibroids, we were able to get post-operative uterine weight to act as a proxy for this important measure. So here I'm just summarizing some of our key findings. We've published these in several different papers. First and foremost, we found that similar to outside of VA, Black veterans were less likely than white veterans to have a minimally invasive hysterectomy. In fact, about half as likely. When we started to look at this by facility and link to facility organizational data, what we found is that this couldn't be explained by differential access to facilities with characteristics thought to really support use of minimally invasive surgery. Further, we did find that Black veterans, on average, had a larger median postoperative uterine weight compared with white veterans. And so at this point, we took a pause and really thought about what does this mean? Again, thinking about race as a social construct, as a proxy for racism. One thing that other researchers frequently attribute this racial disparity in minimally invasive hysterectomy to the differences in fibroid size. However, when we thought about this, we realized that that fibroid size, which here in this figure we define as disease severity, was actually intermediate on the pathway from racism to our outcome of minimally invasive hysterectomy. Therefore, we did not feel that adjusting for for fibroid size was really an appropriate approach. Instead, what we opted to do was to consider fibroid size, or our proxy of postoperative uterine weight, as an effect modifier. And so we essentially looked at how this was associated with minimally invasive hysterectomy among Black versus white veterans. And what you can see in this figure here is that for those who had a smaller postoperative uterine weight defined as less than or equal to 250 grams, among both Black and white veterans, minimally invasive hysterectomy was more likely than among those with a larger postoperative uterine weight. However, the difference within each racial group varied considerably. And in fact, there was about a 29% difference among Black versus a 48% percentage point difference among white veterans, suggesting that postoperative uterine weight was more weakly associated with minimally invasive hysterectomy among Black versus white veterans, and therefore that there were other things going on driving the disparities that we had previously reported. So in conclusion, it's important to note that despite being an enhanced care environment, VA still has racial inequities in uterine fibroid care similar to those reported outside VA. That there are the differences cannot be wholly attributed to fibroid size and number. And therefore, understanding racial inequities in uterine fibroid care really requires us to ask why Black veterans would have larger fibroids at the time of hysterectomy, and to collect data that can capture their preferences and experiences within the VA healthcare system. In terms of clinical and policy implications, I think we're not the first to say this, but access is necessary but not sufficient to ensure equitable health and healthcare outcomes. It is also really important when we're delving into this data to consider both the structural and social determinants of health. And as the number of women veterans increase and VA gynecology practices expand, equity must be considered as a key component of healthcare quality. With that, I will wrap up. Again, I want to acknowledge my co-PI, Dr. Lisa Caligari, our funding sources, our amazing team at VA Puget Sound, our operational partners, in particular, Dr. Christie, who's really been a champion of this work, as well as Dr. Lori Zephyrin, with whom this work started almost 5 years ago now. And then again, our funding sources. And with that, I will close.
Thank you for those excellent presentations. They really illustrate the breadth of research in reproductive health care in VA. I'd like to start by asking the panelists, how can we improve screening of sexually transmitted infections and cervical cancer? And Dr. Caton, how can we best identify inequities in reproductive health care?
Lauren or Elisheva, do you want to take that
I'll
first?
go first. Yeah, so this was also related to a question from the audience about why is testing for chlamydia and gonorrhea so low in women veterans? I want to say first off that it's not that we are not capable of doing this testing. Every VA lab is able to run these tests. So the data that we have so far doesn't tell us, an explanation. It just sort of shines a light that there's a gap. But in my opinion, there is a deficit in provider awareness, and also I think that there can be a complicated mix of stigma of women not maybe aware that the testing is available, where you're not proactive about offering it. It's probably a variety of different factors is my guess. But this area is just crying out for further research because it's really clear that there is a gap here. And there's likely multiple reasons that underlie the gap.
As far as cervical cancer screening, I think that improving screening in the VA should really take a twofold approach. One is in increasing uptake and kind of reducing variation in screening across facilities. But the other is in improving the experience of screening for our women veterans, especially since we know that the majority of women veterans who use the VA have a history of sexual assault, and that this is an invasive and pretty uncomfortable exam for most women. So I think that increasing options for screening, looking at new technology that allows women to do a self-collected screening exam, and improving our training in trauma-sensitive care are all kind of a multitude of approaches we need to take.
All right. So I guess I'll take this. I think it's a little more complicated for uterine fibroids, as this is not a condition that we screen for. We are in the process of conducting a series of qualitative interviews with veterans with uterine fibroids who received a variety of different treatments in VA. And something that we seem to be hearing consistently, and I'm hesitant to say this as this is really preliminary finding, but I think it seems to just keep coming up, is that patients are often unaware of uterine fibroids and are surprised by their diagnosis or had never heard of them before. So I think there's an awareness component, both for patients, but also in thinking about having conversations around, menstruation and really possibly making those conversations more comfortable. The other thing that we keep hearing is that folks aren't necessarily having very detailed conversations with their providers about treatment options. And so oftentimes they're sort of just being told, well, this is what we're going to do, and this is what you need this surgery or this treatment or this medication. And so I think that there is probably a lot of space for developing discussion tools, whether those are shared decision-making tools or something else, for ensuring that patients are really actually getting all of the information and with their providers making informed choices. When it comes to systemic racism, this acts on a lot of different levels, and so I think that you can start to tackle this through provider education, as well as diversifying our workforce and many other things that I think folks who have a much deeper understanding of this have already proposed with respect to many other health inequalities. That's all I have to say.
Thank you. And this is a question for all three panelists. How can you design your studies so that they can best identify inequities in care?
I can start with this. Again, I want to acknowledge that I think one important place in which myself and Dr. Caligari and our study fall short is we are still two white women leading this important study. However, we've really done a lot to try to incorporate the work, the narratives, and the perspectives of Black women, whether they're colleagues or our participants. Something that we are actively doing specifically for our qualitative work right now is we are focusing specifically on the interviews with our Black women veterans, and we plan to actually write up the paper that is focused solely on them. So rather than reinforcing a narrative around sort of a comparison in which white women are kind of considered the default, we are trying to center on the voices and experiences of the Black women in our study. I think probably one of the best resources for trying to understand how to do this better in research is Dr. Chandra Ford's work. She's at UCLA, and she has I always get this wrong, but has published on a critical race theory for public health practice, both a praxis as well as a textbook. And so I would recommend those as resources for anyone who may be interested.
Thank you. And I think we have time for another question. Are Black women made aware of their treatment options other than hysterectomy in the same way as white women?
So I feel like I'm hogging the mic on this. I will say that we don't have the data to definitively say this. However, we are definitely seeing some differences in the conversations that folks are having with their providers. And I think, I think that's all I can say about this right now, but more is forthcoming. And this really is a critically important issue.
I just want to mention someone who's doing a lot of research in this area is Dr. Erica Marsh. And Dr. Marsh, Dr. Caligari, and I had an opportunity to participate in a session in the 2021 ACOG annual meeting about identifying and addressing inequities in the management of fibroids. And so there is some research out there, and there are some programs designed to address things such as provider bias. I'd like to thank the panelists again, and now I'll turn it over to Dr. Patton.
Thank you. Thank you so much, Dr. Christie, and thank you to all of our panelists, as well as Dr. Johnson from panels 1 and 2. We want to thank everyone, and we'll now take a 15-minute break. So we're going to return at 11:15 Pacific time to hear from panels 3 and 4. Thank you.
All right, everyone. We hope you are back from the break, and we wanted to welcome everyone for the second half of our program. We are going to have one more panel of research presentations, and then our final panel will be an interactive discussion around future directions for reproductive health research in VA. I just want to remind everyone to continue to put your questions and thoughts in the Q&A box to your right. Feel free to do that while presentations are ongoing, although we will hold the active Q&A till the end. I'd like to now introduce our discussant for our third panel, Reproductive Mental Health from Pregnancy to Menopause. Dr. Laura Miller, Medical Director of Reproductive Mental Health for the VA Office of Mental Health and Suicide Prevention. Dr. Miller will get us started by briefly introducing our panelists before moving to their presentations. Dr. Miller, over to you.
Thank you so much, Dr. Caton, and I'm really thrilled to be able to introduce this terrific set of panelists who will take us through their research related to reproductive mental health across various parts of the life cycle, starting with Dr. Jonathan Shaw, who is Program Analyst at the Women's Health Evaluation Initiative at VA Palo Alto, and also Clinical Associate Professor at Stanford University School of Medicine. Importantly, he is a family physician who has practiced across several safety net healthcare settings and brings that clinical expertise to a research career that focuses on vulnerable populations, particularly including psychosocial determinants of health for women. He also, as a postdoc, developed and analyzed the first comprehensive cohort of VA-covered deliveries with a focus on the adverse impacts of antepartum PTSD in veterans, and more recently is focusing on implementation science as medical co-director of Stanford's Evaluation Sciences Unit. Next up, we'll have Amy Kroll-DeRosier, who is a research health scientist at VA Central Western Mass and University of Mass Medical School, where she's an assistant professor. She has a VISN-1 Career Development Award to study VA perinatal depression care pathways, and is going to share some of that with us today. She also is currently working to study unemployment among veterans and uses mixed methods studies to investigate women veterans' mental health and healthcare utilization, especially during the perinatal period. And finally, we'll also hear from Carolyn Gibson, a clinical research psychologist at San Francisco VA Healthcare System and assistant professor of psychiatry and behavioral scientists at University of California, San Francisco. She's a clinical health psychologist who has a Research Career Development Award at the San Francisco VA. It also provides clinical services in the Women's Mental Health Program there and focuses on women's physical and mental health as it relates to menopause, perimenopause, and aging. And she'll share some of that with us now. So now I'd like to turn this over to get us launched to Dr. Shaw.
Thank you so very much. It's a true privilege to be here today. And while I get my slides up, I just want to acknowledge that this work would not have been possible without really 10 years of mentorship from Susan Frayne and Kieran Phibbs. And I really appreciate the collaboration of the past decade that I've been in the VA, also with Jody Caton. So let me see, I'm trying to get my slides. There we go. So I'll be presenting epidemiology of mental health and pregnancy outcomes in veterans. And this represents, like I mentioned, work that I began in my fellowship 10 years ago, and what we've learned from the data, quantitative data of veterans' pregnancies and birth outcomes. And as been mentioned, we all know that growing number of veterans of reproductive age are enrolled in the VA, and really it's been since 2000 that a significant number of veterans started to use the VA maternity care benefit, and an increasing number are relying on the VA for maternity care, and we know they have high burden of mental health and trauma history. When I began this work, we really didn't know the impact of PTSD and trauma on pregnancy. It was poorly understood. There had been smaller studies, especially by people like Dr. Julie Sang out of Michigan, suggesting that PTSD was linked to poorer birth outcomes, but small numbers. And the other thing that Kristen Maddox, for those who were on this morning, pointed out very well, pregnancy represents this unique transition. It's an important healthcare event in all pregnant individuals' lives, but also it's this transition for veterans in the VA, in that they necessarily have to leave the VA to get non-VA community care because the VA hospitals don't provide obstetric deliveries, and the prenatal care largely is through the community. So it raises a lot of interesting questions about utilization and access, and in particular outcomes is what I first approached this work from, wondering what the outcomes were for these veterans. I, as a family physician, came to the VA having provided maternal and child care in other safety net settings, and I was particularly interested in the psychosocial factors that and how this would translate to outcomes, and particularly that, it became obvious as I entered the VA that PTSD was uniquely concentrated in our patients. And so that's what we looked at. Our initial cohort, our birth cohort, represented these first 12 years. And this graph shows the growth. There's a little lag in when we get data from when the births occur. But we had over 16,000 births that we looked at, and not shown here is that we've actually updated this with the last 5 years of data, and it's continued to be over 5,000 births per year that the VA is covering. And so we now have a cohort of over approaching 60,000 veteran births that we can analyze. So our approach, as I mentioned, is quantitative analysis of the VA administrative data. And what this allows us, we have the delivery claims for non-VA care. So those very clearly outline the maternal outcomes, all the diagnoses, what happened in the delivery, and any hospitalizations before or after the delivery, hospitalization plus prenatal care. And linking that to the VA clinical data gave us not only medical diagnosis information, but we were able to leverage the robust mental health data, and particularly the fact that there's universal screening within the VA for PTSD, along with sociodemographic data. So our early work looked at national outcomes for all the VA covered births in about the first decade of 16,000 deliveries. And specifically, we were focused on PTSD's impact, and began really with one of the most common outcomes, which is preterm birth. And preterm birth, just say, is particularly important because not only is it common, but it has a significant cost and health and social implications for mom and the infant. For severely preterm infants, it can lead to significant lifetime impairments, and for those preterm births that really don't lead to long-term consequences, there's high cost upfront for the extra level of care in NICU and prolonged stay. So that was our initial focus. We then looked at other common pregnancy outcomes, as well as once we established the PTSD affected pregnancies were leading to a higher risk and more complex pregnancies and births, we wanted to step back and look at how the VA enrolled veterans compared to their veteran peers who maybe weren't relying on VA maternity care, as well as the general population. So using methods that Karen Phibbs and Susan Schmidt here at the VA Palo Alto had developed, and the partnership with the California data, we were able to link VA and California data and look at, that gave us a view not only of the VA covered veterans who were using maternity benefits within the VA, but also those veterans who were enrolled but were using private or Medicaid insurances, and compared directly to the general population. And it also gave us a chance to look in more detail at the infant outcomes. So our key findings from our initial analysis of the first 16,000 VA covered births, one, we found that PTSD affected pregnancies were very common. Antepartum PTSD, so we defined it as those individuals who had a VA diagnosis recorded during the year leading up to their delivery was 12%. So more than 1 in 5, more than 1 in 8 women had PTSD in their pregnancy, and actually upwards of 20% of women had a PTSD diagnosis anytime in the past within the VA covered births. And so PTSD was we had very high power, and we were able to demonstrate definitively that PTSD was associated with increased risk of preterm birth, a 35% increased risk. And this was more so than any of the other mental health associations. Now, only depression was more common than PTSD, and it didn't show this strong signal for preterm birth. We also looked at less common mental health conditions like anxiety and schizophrenia, bipolar. Military sexual trauma was very prevalent. 1 in 4 of the pregnancies had a positive history of military sexual trauma recorded in the VA. And while it's antecedent to PTSD, or can be, it was not itself predictive of preterm birth. So then we went on to look at some of the more common antepartum complications of pregnancy that could themselves actually lead to preterm birth. And two of the most common, actually the 2 most common complications of pregnancy both turned out to be higher prevalence among those women with PTSD, specifically gestational diabetes and preeclampsia, both of which affect about 6% of pregnancies. Gestational diabetes had a 50% increased risk, preeclampsia a 30% increased risk. And preeclampsia is particularly relevant because it itself is a major cause of preterm birth, both spontaneous but also frequently medically indicated delivery before term, because the definitive treatment for preeclampsia, which is a hypertensive disorder of pregnancy, the definitive treatment is delivery. So this fit with our prior findings showed clarified the picture of some of the complications that might have been leading to the increased risk of preterm birth. And then we also looked at what this meant in terms of healthcare utilization for the cohort of pregnancies that were affected by PTSD. And we saw that they were much more likely to have repeat pregnancy hospitalizations, 50% more likely to have more than just the delivery hospitalization during their pregnancy, and also more likely to spend more time in the hospital after their delivery. So having established that the PTSD affected pregnancies were at risk, were at higher risk, we wanted to look at what this meant more generally, and did it translate outside the VA covered births. And so by linking to California data, we were able to look at all VA enrolled veterans and look at those who relied on maternity care from the VA, but also those who relied on private insurance and Medicaid. And first, for context, what was really interesting, we saw that the number started very small of those veterans who relied on the VA maternity care, much more common. Over half of women who were enrolled in the VA were actually relying on private insurers. So it points to the veterans that we're seeing within the VA and that we can see their claims and outcomes are just the tip of the iceberg. But by 2012, the VA covered veterans, the percent relying on the VA maternity benefit equaled those relying on Medicaid. And it'd be really interesting to see what's happened since the Affordable Care Act, and hopefully we'll be able to with our newer, larger cohort, revisit this. So overall, what we found is that the VA covered pregnancies did show similar outcomes, with notable exceptions that compared to privately insured veteran deliveries, there was more preeclampsia, odds ratio 1.4 among the VA covered veterans, and a slightly higher cesarean section rate. The other thing we saw in veterans overall compared to non-veterans was that infants were more likely to end up in the neonatal intensive care unit. And this is not a rare event. Among the VA covered births, almost 14% of infants ended up in the NICU. So from this, what I showed here represents three different papers and sort of a succession of diving into the degree possible into the quantitative data. And what it shows is that the mental health comorbidities that we see in the veterans definitely have significant real physiologic impacts on pregnancy. and that the VA as such covers a high-risk pregnant population because of the prevalence of PTSD and other mental health conditions. And that the VA pregnancies are highly impacted by PTSD, and that these births are most likely to be medically complex with antepartum complications and end in poor birth outcomes, including preterm birth, and that these can have long-term health implications for both the mother and the infant. I think a lot of these the policy implications, Kristen Maddox spoke to really well, and I would just highlight that I think it's wonderful to see the mixed methods approach, and what I was sharing is really what we can find from the data, and to us it's really important to prospectively continue to follow what's going on with these outcomes. But the findings of the mental health impacts on outcomes in pregnancy reiterate the importance of the maternal care coordination efforts that are ongoing, and the need for more focused investment on perinatal mental health services, as well as further study of maternal fetal impacts of veterans' mental health. And in terms of what's next, access to high quality perinatal care, surveillance of severe maternal morbidity and mortality is the area we're really focused on now, looking at our large data specifically with a health equity lens, and looking for the gaps, racial and ethnic gaps in these severe, rare but severe outcomes in pregnancy. So with that, I will end and pass off to our next speaker.
Thank you so much, Dr. Shaw. We're now going to hear from Dr. Kroll-DeRosier.
Thank you, everyone. It's an honor to be here today to present my work on perinatal mental health and healthcare utilization among veterans. Okay. So this work started about 6 years ago. And we started looking at it because we knew perinatal depression is one of the most common complications of pregnancy in general. However, we hadn't done much work in this area yet among women veterans. However, we did know that about 25% of women veterans in general, ages 18 to 44 or reproductive age, were diagnosed with possible depression. So we knew that depression was prevalent in this population. As Dr. Shaw just alluded to, there's been an increasing use of VA maternity benefits over the past couple of decades. And as I just mentioned, there was a real gap in understanding mental health diagnoses and mental health care utilization research in the perinatal period. So our research questions were as follows. We were interested in knowing the rate of depression symptoms in pregnant veterans. We were also curious if pregnant veterans with depression symptoms were utilizing VA mental health care during pregnancy. We wanted to know more about the experiences of VA mental health providers with pregnant and postpartum veterans. We also were interested in looking at whether veterans were being screened for depression during the perinatal period. The data that we used to answer all of these questions came from Dr. Kristen Maddox's COMFORT study. As she detailed earlier, this was a study that took place over the past 6 years. We used mixed methods data from prenatal and postpartum surveys, as well as VA administrative and electronic health record data and qualitative interviews. We had over 1,300 pregnancy and nearly 1,000 postpartum interviews. And you can see that we enrolled women from 13 states as well as Puerto Rico. So some of our key findings to answer our first research question about pregnancy mental health and mental health care utilization. We examined depression symptoms in a COMFORT sample of women who are pregnant using the Edinburgh Postnatal Depression Scale, or the EPDS. We found that women who had an EPDS score of 10 or higher, which is indicative of depression symptoms, this occurred in about 28% of our sample. And I will note that this is higher than what we typically see in a general population sample. Some of the risk factors we found that were specific to veterans were unemployment, a history of anxiety and depression, as well as past active duty status. We found that support from a partner or significant other was a protective factor for depression symptoms during pregnancy. We then examined just this sample of pregnant veterans who had depression symptoms. to explore whether they were utilizing VA mental health care during pregnancy. Indeed, we did find that over 70% of these women had one or more VA mental health visits or had received an antidepressant prescription during pregnancy. However, women veterans who self-reported a history of depression were more likely to receive mental health care during pregnancy. And this may suggest that women veterans who were engaged with VA mental health care prior to pregnancy were more likely to receive that care during pregnancy. Next, we conducted interviews with VA mental health providers to ask them about their experiences of working with pregnant and postpartum veterans. One of our key findings, a key theme that we found, was that there was a concern among mental health providers that symptomatic veterans may, quote, be slipping through the cracks. As one mental health provider said, "We know that there's underdiagnosed and underreported cases of depression. I think if we more routinely screened for depression, we would probably catch some cases we're not aware of right now." Another finding we found was that there were challenges with care delivery when there was no communication with obstetricians. So mental health providers spoke about how challenging it could be when they really didn't have a way to reach out to the community providers that the veterans were seeing. And as one mental health provider said, "I don't necessarily know what the OB is doing because there's not real good communication when the OB care is farmed out. And a lot of obstetricians are very uncomfortable with mental health medications. So I never know how comfortable they are with what I'm doing." Speaking with the VA mental health providers really got us thinking more about depression screening in general and how often it was occurring. And so we went into the data that we had available, which was in VA administrative records, to examine whether depression screening was recorded on health records during pregnancy or postpartum. So we found that 59% of our sample had no recorded depression screen on their electronic health record during pregnancy or postpartum. We found that about 40% of women had one or more screens during the entire perinatal period. Interestingly, we found that there were no differences in receipt of primary care or mental health visits between veterans who were screened or not screened during pregnancy. So this is just to say that screening didn't differ by whether or not women were seeing a VA provider during the perinatal period. They all had a chance to be screened by a VA provider, but it was not happening with the majority of our sample. So to kind of wrap all of this up together, we did find that mental health care, VA mental health care, I should say, is certainly available during the perinatal period, and that women veterans in the COMFORT study who were engaged with VA mental health care prior to pregnancy tended to stay engaged during pregnancy. This is great news. However, we did find that women veterans without a previous diagnosis of depression may be less likely to receive needed mental health care during pregnancy. I will say that although we did look at perinatal depression screening records in electronic health information, the true estimate of screens is unknown. And this is because it's really unclear if screening is happening, if it's because screening is not happening as recommended, or if some of this data is just not reflected in the electronic health records. A lot of the screens are conducted by maternity care coordinators, and they may have their own way of collecting this information. However, this could be a potential point of intervention in the future. And I do believe that there's some changes being made to the electronic health record where there'll be a template to collect this type of data, which will be helpful. We currently don't have any data on provider efficacy in providing perinatal care. In some of the qualitative interviews we've conducted, there's been some hesitation by some providers, both mental health care providers and primary care physicians, on treating pregnant veterans because oftentimes they don't do it very, very often. So it'd be interesting to examine provider efficacy. I think looking into social support some more is important. We did find that it's protective of depression symptoms. And also in some recently conducted qualitative interviews, we've had women veterans reporting that they'd like more from other veterans in particular. And so potentially looking at virtual support groups for veterans who are pregnant at the same time, I think may be useful and another point of intervention. My work really focused on depression, as this is one of the more common mental health conditions during pregnancy. But certainly we need more research on other mental health conditions like anxiety, PTSD, bipolar. Dr. Shah just talked about PTSD and how common it can be in women veterans, pregnant women veterans. So I think focusing on these other conditions as well is important. And finally, some of the preliminary work that we've been conducting suggests that both veterans and providers are accepting of increased mental health care during pregnancy and postpartum. And so I think looking into this a little bit further, there's support for interventions to increase mental health care and receipt of mental health care during this really important time period. And that is all. Thank you so much for listening.
And thank you so much. We will next hear from Dr. Gibson.
All right, well, thanks so much. I'm thrilled that today is happening and to be here to talk a little bit about women veterans' mental health at the other end of the reproductive lifespan, or in and after the menopause transition. So to start, just to make sure we're all on the same page, menopause is officially marked as 12 months after the last menstrual period. In the US, that happens on average around age 51, though there's certainly variability in age and also how individuals get there. Natural menopause is preceded by several years of hormonal fluctuation and menstrual cycle irregularity, or the perimenopause, and followed by the postmenopause, which can be a third to a half of a woman's lifespan. And this is really a pivotal point within the lifespan. When I talk about the menopause transition, I'm primarily focused on perimenopause and also well into the postmenopause. Basically, this broad period where we often see a number of important changes as well as common symptoms. So some of the changes that often occur during this point in the lifespan, one are significant life stressors, role changes, social changes. Just think about all the things that women juggle across the lifespan, but particularly in their 40s, 50s, into their 60s. This tends to be a time of change and important life stressors. It's also a time of accumulating and changing health risks, particularly for cardiovascular disease and bone health in the postmenopause. And it's also a period of vulnerability for mental health. And most well established is that the perimenopause is a period of vulnerability for depression, when women have a 2 to 5 times the risk for a major depressive episode in perimenopause compared to other points in the lifespan. That's particularly for women with a history of depression prior to this point. The menopause transition is also often characterized by common menopause symptoms that for some are no problem, but for others can be incredibly bothersome, disruptive, and have a significant impact on quality of life and well-being. There are over 30 symptoms that are listed in this category, but I'm going to focus on the core 4, most kind of common and impactful. And those include hot flashes and night sweats, which are most common in the years just right around menopause, but can start 10 years before menopause and continue for years or even decades after, reported by up to 80% of women at some point in the menopause transition. Sleep disturbance, which is commonly reported in perimenopause and after. Genitourinary symptoms like urinary incontinence or vaginal symptoms that may influence quality of life and sexual function, which often emerge with the hormonal changes of perimenopause and then can be chronic and progressive across the lifespan. And mood changes. So in addition to things like that depression risk during perimenopause, irritability, anxiety, even rage, mood swings can be commonly reported, particularly in the perimenopause. And all of these common menopause symptoms are strongly and consistently associated with depression and anxiety. And so why do we care about this in the VA? Well, in part because it can be incredibly impactful on quality of life and functioning, and also just by numbers. So this affects a lot of the women veterans that we serve. The largest group of women veterans in VA are in the age category of 45 to 64, really prime time for these common changes and potentially bothersome symptoms related to peri and postmenopause or the overall menopause transition. And over half of women veterans are aged 45 and older, or are likely to be affected by these changes in symptoms. Despite this, we don't know much about the experience of menopause or menopause symptoms for women veterans, or that much about the relationship between bothersome menopause symptoms and other important issues related to mental health that we tend to focus on in the VA, beyond depression and anxiety. So I'm going to give a very brief overview of a few studies that we've conducted trying to understand some of these associations. And I apologize here, the lack of animation might make these slides a little less pretty. So first, we conducted a few studies using national electronic VA health records to identify bothersome menopause symptoms among midlife women veterans, so those aged 45 to 64. And we identified menopause symptoms by looking at ICD codes indicating symptoms and menopausal hormone therapy, which is frontline treatment for bothersome and severe hot flashes, night sweats, and genitourinary symptoms. This isn't going to capture all symptom experience, but one, it's kind of the best that we could do with medical records, and then also ideally captures those symptoms that rose to the level of discussion, documentation, treatment seeking. So first, we looked at the relationship between bothersome menopause symptoms and chronic pain among midlife women veterans. And among those midlife women veterans, the relationship with chronic pain, the relationship between menopause symptoms and chronic pain management, particularly potentially high-risk opioid prescribing. In a separate cohort, again, using national VA electronic health records for women veterans aged 50 and over, we looked at menopausal hormone therapy as a proxy for bothersome symptoms in relation to suicide risk. And then finally, I may present just some currently unpublished data from a survey study of 232 women veterans aged 45 to 64 in Northern California, where we're able to delve a little bit deeper, really get a sense of current bothersome menopause symptoms and the relationship between those symptoms and trauma exposures, particularly intimate partner violence and military sexual trauma and PTSD. I think in particular, as has come up in several of these talks, the relationship between PTSD and some of these reproductive health outcomes is a particular area of kind of interest and importance where there's a lot that we don't yet know. So starting with the data from our national cohorts from electronic VA health records. First, we find that when you look at women veterans aged 45 to 64, half of women have documented chronic pain. This is incredibly common at this point in the lifespan. And those women who had indications of bothersome menopause symptoms, so again, ICD codes or menopausal hormone therapy, had about twofold odds of having chronic pain. Among those women with chronic pain, those who had indications of bothersome menopause symptoms also had higher odds of potentially higher risk opioid prescribing patterns. And that includes being prescribed long-term opioids, being prescribed high-dose long-term opioids, and being co-prescribed long-term opioids along with other central nervous system depressants, including sedative hypnotics, gabapentin, which I should note can be prescribed off-label for hot flashes, and muscle relaxants. And that's despite the increased risks for misuse, overdose, and mortality that these medication combinations can bring. And then finally, among those women aged 50 and over who were prescribed menopausal hormone therapy at baseline, they had about twice the risk of dying by suicide over the subsequent 5 years. And that's controlling for independent of age, demographic variables, mental health and medical comorbidities, and psychoactive medication use. All right, next in our survey data, delving a little bit deeper into some of these symptoms that women are experiencing. One I'll note, if you look at the bottom of this screen, when we looked at the medical records for these women, about 30% had some ICD codes indicating menopause symptoms. So we would have maybe caught that when looking at the broader records. But over 70% reported one or more of these 4 most common symptoms within the past 2 to 4 weeks. And that includes almost 70% reporting vaginal symptoms, such as pain with intercourse, over half reporting hot flashes and night sweats within the past 2 weeks. And for these 2 most common symptom categories, 50 to 80% of women reported being moderately or significantly bothered by these symptoms. Almost half had urinary symptoms like incontinence or nocturia. And while just about everybody reported sleep difficulty, 36% of these women met criteria for moderate to severe clinical insomnia based on the Insomnia Severity Index. Women who had a history of interpersonal or intimate partner violence, military sexual trauma, or had current clinically significant PTSD symptoms based on PCL also had 2 to 6-fold odds of reporting a number of these common symptoms. So overall, in conclusion, I think this suggests, one, that bothersome menopause symptoms or menopausal hormone therapy, which may be a kind of an easily identifiable marker of bothersome symptoms when looking at medical records, may indicate a complex comorbidity underlying the symptom burden. And that complex comorbidity may also put women at risk for some treatment decisions like polypharmacy that can put them at risk for a number of adverse outcomes related to mental health and functioning. We also know that menopause symptoms are common and likely under-recognized in the healthcare setting. We don't know when we don't ask. And that those women who have experienced interpersonal trauma and or have mental health comorbidities may have the greatest burden of menopause symptoms. So a number of gaps and next questions remain that we're pursuing or hope to get to. But overall, I think this data suggests, one, that comprehensive care for women includes recognition of the role of menopause and menopause symptoms, and the experience and management of other conditions. That includes depression, conditions like depression, PTSD, as well as chronic pain, as we saw here. And that overall we need integrated approaches to comprehensive trauma-informed menopause-related care in the VA and all healthcare settings to best support the mental health and well-being and overall health of women during and after this vulnerable period. So thanks so much for your attention. I just want to acknowledge my mentors and collaborators and funding sources for some of the projects I presented today.
Thank you so much, Dr. Gibson, and all of the panelists. I have some questions for you. Starting with a question for you, Dr. Shaw, which is, what are the implications so far of your research as it relates to clinical practice for women veterans with PTSD who are of reproductive age?
That's a great question. So the American College of Gynecology, Obstetrics and Gynecology, a few years back, worked with representatives of the VA and DoD and did put out a practice bulletin highlighting that, actually not just for pregnancy, but for reproductive health in general, that veteran status and military service is something that all providers of obstetric and gynecology care should be aware of. So I think it's making sure that as a community of providers and clinicians, we're asking about service history, because as we see, the majority of veterans actually aren't even tied into the VA for maternity care when they're getting their pregnancy care. So I think increasing awareness to ask about service, and then also there's a push to screen universally in pregnancy for PTSD. So that's beyond the VA. And we've screened universally within the VA, but revisiting that at the time of pregnancy, I think, is particularly important. In addition to depression, which over the past decade or two really has been more routinely screened for in pregnancy and postpartum. So I would say that the elevating awareness of PTSD, especially awareness to ask about service history in the general community outside the VA, is one of the key takeaways.
Thank you so much. This next question is for you, Dr. Kroll-DeRosier. Could you elaborate more on the concept of enhanced mental health care during pregnancy?
Sure, yeah. So this is something that we've been looking at further, particularly in regards to the U.S. Preventive Services Task Force recommendations that came out in 2019, which suggested that women who are at high risk of perinatal depression be referred to mental health counseling at the beginning of their pregnancy. And so I've been working on conducting interviews with pregnant and postpartum veterans, as well as VA providers, to ask them about these recommendations and how they thought that this might be implemented in the VA. And both veterans and providers were supportive of greater mental health involvement, whether that meant at the beginning of pregnancy for women who weren't already connected with a VA mental health provider to make that connection with a provider, as well as during pregnancy. Perhaps women wouldn't want to be engaged with a provider and have extra visits throughout her pregnancy, but at least having someone there that they could reach out to if needed. So this is kind of the concept of enhanced mental health care that we've been examining, and we found a lot of support, like I said, from both sides. So certainly something to look more into.
Thank you. And for Dr. Gibson, you underscored at the end of your presentation the importance of recognition of menopausal symptoms and their links with some of the mental health concerns that you raised. What are some preliminary thoughts about how to foster an increase in that recognition between not only recognition of perimenopause and menopausal symptoms, but also their connection to issues such as suicidal thoughts, trauma, pain, and other mental health concerns?
Yeah, I think it's just really important to normalize these symptoms, right, and to have it be a part of healthcare discussion. You know, particularly within the primary care setting, it gets a little fuzzy because, you know, but we can particularly focus on this among women who are in the age range where we think they might be likely to be in perimenopause, and making sure to ask questions about symptoms, particularly some of these more sensitive symptoms that people are pretty reluctant to bring up, like around sexual function, urinary incontinence, and then just providing, you know, trauma-informed psychoeducation about how that may relate to other issues. I think it's important to note that, again, these symptoms can go well into the rest of the lifespan. And for many women, maybe due to hysterectomy, oophorectomy, or early menopause, or different factors, they may be present even earlier. So maybe it's a part of sort of screening, recognition, discussion, and just normalization for all, you know, women as they're getting care in primary care as well as in mental health.
Thank you. And Dr. Shaw, you place your research in the context of a larger body of research about antenatal distress and outcomes for pregnancies and offspring and women. How might PTSD differ from other forms of antenatal distress in regards to its effect on outcomes?
That's a great question. There is a lot of work out there epidemiologically looking at stress during the antepartum period, natural disasters, family loss, that also shows impact on outcomes, and particularly preterm birth and birth weight. So in some ways, I think it fits with that larger body. It also, I think the PTSD creates a unique opportunity because increasingly, we're understanding it has real and lasting physiologic impacts long-term beyond the acute stress. Impacts on cardiovascular health have been shown from colleagues up in the VA. Impacts on cortisol levels chronically and sensitivity to hormone changes, stress hormone changes. And then brain structure changes have been consistently shown in PTSD. So when we entered into the research, our hypothesis was that the pathological and physiological changes of PTSD, one pathway, there are a few different pathways. One is that the HPA axis, the hypothalamic pituitary adrenal axis of stress hormones, are known to be really important in the quote placental clock when labor begins. And so that could be one impact, and how PTSD directly impacts when labor and preterm birth occurs. But the other is very much could be behavioral and risk factors. We know that more risky behavior, substance use are certainly more prevalent with mental health conditions, and particularly PTSD. So we actually looked at that in our data to the extent that we could, and adjusted and accounted for substance use diagnosis and other comorbid mental health, and saw that PTSD, independently of what we could adjust for, was impacting that. So, all that is by way to say we don't understand preterm birth well at all, even though it's one of the most common and impactful poor outcomes in pregnancy, and there's still a lot we don't understand about PTSD. But I do think that things like the Million Veteran studies and basic research, if we can bring that in as we build up our research of PTSD and pregnancy, there's a lot of potential to actually understand more about the impact of stress and PTSD as a lens into chronic stress impacts on pregnancy.
Thank you. And Dr. Kroll-DesRosiers, what are the implications so far of your research with regard to the role of maternity care coordinators?
That's a really good question. I didn't talk a lot about the maternity care coordinators in my presentation, but I would like to point out how integral they are to this entire experience for veterans. You know, it's such a unique position that we have in the VA, and I think it truly improves the care that our women veterans are receiving, especially in the way that coordination is happening between the veteran, her VA providers, and her obstetrics team. And so I think, delving a little more deeply into the maternity care coordinator experience and better understanding their resources and limitations to their resources, I think would be important to, improve the maternity care coordination that our veterans are receiving. And so, that's something that we hope to explore a bit further.
Thank you so much. I'm now going to turn this over to Dr. Caton to introduce our next panel.
All right. Excuse me. Thank you, Dr. Miller, and all of our amazing panelists for highlighting the many connections between reproductive and mental health. We are now going to move to our fourth and final panel, which is an exciting opportunity to discuss future directions in reproductive health with leaders from operations, research, health systems, intergovernmental affairs, and veteran experience. I'm going to turn it over now to Dr. Patton to introduce and moderate our final panel. Dr. Patton, all yours.
Thank you so much. And thank you to all our panelists today. I want to take a moment to invite our panelists, Dr. Amanda Johnson, Dr. Lori Zephyrin, Dr. Kara Zivin, and Ms. Kayla Williams to unmute themselves. And while they're joining us and getting all set, I want to invite the audience to put your answer to the following question in the chat. What are 1 to 3 key priorities for VA reproductive health research over the next 5 years?
This is Kayla. Good afternoon, and thanks so much for having me.
Thank you so much for joining. And I'm sorry for the CIDR team, I am not able to advance the slide. So could you advance to my next slide, please? Thank you. So audience, again, please put in the chat, based on your expertise and what you've heard today, what are 1 to 2 or 3 key priorities for the VA reproductive health research in the next 3 to 5 years? While the audience is putting their thoughts in the chat, I'm just going to give a quick overview of what we'll do for the rest of our time together. In our last panel, we are going to draw from what we've heard today and from the expertise of our panelists and you, our audience, to consider the question of where should we go from here? We want to think about charting a course for future VA reproductive health and a research agenda. What I'd like to do is briefly introduce each of our panelists, and then I'm going to ask them to comment on a similar question to what I've asked you, the audience, to comment on. So panelists, I'm going to be asking you, from listening to today's conference and from your expertise, what themes or directions have emerged for you that should shape the future directions of VA reproductive health research? What I'll do is I'll introduce each of you in turn, and then I'll take you in order and ask you your answer to that first question. If when you answer, you could just give a quick indication to the audience of how your current role or expertise or perspective influences your answer, I think that would be really helpful context for the audience. So let me just get started with a quick rundown of who we have today. We have Dr. Amanda Johnson, who's the Director of Reproductive Health for the VA Office of Women's Health, and she's a practicing gynecologist in the VA. She's field-based in Wyoming. We have Dr. Lori Zephyrin, also an OBGYN by training. She's a Vice President for Advancing Health Equity at the Commonwealth Fund, and she was the first Director of Reproductive Health for the VA, so she knows the VA reproductive health world very well. We have Kayla Williams, who's the Assistant Secretary for the Office of Public and Intergovernmental Affairs in the Department of Veterans Affairs. And we have Dr. Kara Zivin, who is a core investigator and research scientist at the VA Ann Arbor Center for Clinical Management and Research, and also a professor of psychiatry, obstetrics and gynecology, and health management policy, all at the University of Michigan. Go Blue. So what I'd like to do is, Amanda, Dr. Johnson, if I can start with you and ask you to give us some thoughts about what themes or directions have emerged for you that should shape the future directions of VA reproductive health research?
Absolutely, and thank you for including me in this excellent conference. So just a brief sort of insight into my perspective. So as you mentioned, I'm currently Director of Reproductive Health in the Office of Women's Health and VA Central Office. And so my perspective is one that comes from my role, which is to support the field, providing reproductive health care to veterans. So that includes supporting our gynecology workforce, our primary care workforce, and then in addition, our other program offices. Another role that I have is to be responsible to answering questions by Congress about questions about the care that we give to veterans in the area of reproductive health. And then also to sort of have an eye towards strategic planning, looking at our population and looking at what we can do to really translate research into practice. To answer your question, I think a few themes kind of seem to sort of come through to me. One is a real need for focus on health equity, reducing racial and ethnic disparities, focusing on gender perspective as well as sexual orientation. When we look at programs around reproductive health for veterans, I think language is really important, and it's something that we certainly think about in our office. We are the Office of Women's Health, but we understand that, that we are really serving people of, potentially of reproductive capacity, or people who are female, or people who identify as female. So we want to be more broad and inclusive there. The other piece that came out to me is the really essential role of acknowledging mental health comorbidities of veterans, including a trauma history. It's clear that it's important and potentially higher than the general population, as well as other mental health comorbidities. So those two themes of equity and acknowledging trauma and mental health comorbidities certainly came out. When I think about sort of where we need to go, I think about the population of veterans we serve. Certainly there's the population of veterans who are either experiencing, having maternity care or seeking family building or family planning services, so fertility services. But then we also see that a large group of our population is midlife. So those menopausal concerns that come up, which are significant, sexual function, including sexual pleasure, I think is important to address, and there's definitely a need for that for the veteran population, with female veteran population, and then sort of other issues that are affected, or that affect veterans in midlife. So thinking about things like pelvic floor disorders, urinary incontinence, those issues I think could use some additional attention, again through that lens of equity and trauma-informed care. The other piece that I think about is really essential is how do we translate all this excellent research into sort of the three P's, policies, programs, and practice. How do we get this excellent work to really truly be translated and make a difference for the veterans we serve? I hope that answers your question adequately.
That was perfect. I have written down many ideas already, but let's go next to Dr. Zephyrin to answer the same question from your expertise and from what you've heard today. What stood out to you in terms of themes or directions for VA reproductive health research going forward?
Thanks for having me, and amazing conference. It's just so fantastic to see the depth and the breadth of the research that's happening, and really the link between research and operations. I think what's exciting about the VA and the VA healthcare system is really to be able to, link the research to actually improve how veterans experience care. And I think there's a lot of opportunity for that, which is fantastic. I think the piece around further understanding inequities of care around race and ethnicity, I think are definitely important. Race, ethnicity, gender, etc. and really being able to further understand what are the systematic and structural roles or ways that that the system can really help with eliminating inequities and moving it from person to system, and what are responsibilities of the system. And I think there are a lot of opportunities there in developing of frameworks. The VA is a very unique place because veterans have access to amazing healthcare, and so theoretically that the access piece and the is not there. And so really, how can one improve the experiences of care for veterans in a meaningful way? I mean, I sort of think of things in two ways. One sort of internal to the VA healthcare system, right? And so what are ways that we can better understand the lived experience of women veterans that are utilizing the VA healthcare system across all the intersectionalities that one experiences, and how does that intersection of reproductive health link to other aspects of care, whether you're talking about mental health, which Dr. Johnson talked about, or primary care, which or other specialty care, and really making those transitions a bit more seamless, I think is really, really important as well. And being able to better improve the experiences and utilizing the research to improve sort of the journey within the healthcare system. I also think of it sort of outside of the VA, and just also looking at it from a policy and practice perspective as well. And what can we learn from our experiences within the VA healthcare system? And I say our because I still practice in the VA. And what are best practices that we can export? I think there's a lot that can be learned. I think Dr. Caligari's MyPath and some of the other research that was presented today, there's definitely a lot of relevance just more broadly, which is really important. And also better educating and making those linkages around women's veterans experiences outside of the VA. I mean, there's still people to this day that are surprised to hear about just all the amazing work that all of you are doing inside of the VA. And I'd say lastly, just as policies are being considered more broadly to address veterans and their experiences, there's a lot of opportunity to study the impact of these policies, whether you're talking big P policies outside the VA from the federal perspective or little p policies. And I think there's a lot of opportunity for research to be able to address, are these policies working? Is there an impact? Are inequities being decreased or erased? And what are best practices there? So I'll stop there, but thank you so much for including me in this great conversation.
Thank you so much, Dr. Zephyrin. Assistant Secretary Williams, we would love to hear your perspective next. So again, the question is, from your expertise and perspective, what stood out to you for future directions for VA reproductive health research?
Thanks so much for having me. It's really a tremendous honor to join so many truly exceptional researchers, and also, frankly, to hear some familiar voices like Dr. Maddox and Dr. Christie. It's hard to follow the two folks who have already commented, especially since, while I have a decent amount of experience in doing social science research, I don't have experience doing explicit medical research. So happy to share, though, my perspective, such as it is, from both my current seat and also, frankly, as a woman veteran who uses the VA system and is midlife. So, I was definitely listening to some of these and thinking about my past experience or current or future experience. Some of the topics that I was particularly interested to know that researchers are looking into right now were on MST and maternal bonding and vaccination hesitancy among pregnant women veterans, and infertility prevalence and STD testing and menopause symptoms. So, it's fantastic to know how much research is going on, the breadth and the depth. I think the 3 Ps that were already mentioned, so incredibly important. I also wrote that down. I've heard the phrase research into practice a lot of times, but I love that focus on not just practice, but policy and programs as well. And I noticed that a lot of the presenters talked about how to convey this, what they're learning, to, I think, providers. And from where I'm sitting, another core component of that is how can we take that further to convey it directly to veterans? So one of my top priorities lately in my current role, for example, is how can we use VA's public and intergovernmental affairs capabilities to encourage veterans to get vaccinated? And this question of how to overcome that vaccine hesitancy among pregnant women veterans is a big issue to consider right now. So how can that research that's being done inform not just how specific providers have conversations directly with their patients, but the types of social media posts that we're putting out, or should we have specific flyers, or and what kinds of interviews should we try to get people to engage in, and how can we take that and make it public facing? Another thing that occurred to me is, in what ways can or should researchers think about connecting to VA's strategic plan when it is the new version is released, especially to specific agency priority goals? For example, I know we at the senior leadership level are focusing heavily on toxic exposures. So do toxic exposures influence any of these topics that have already come up today, and how, if at all, can we do additional research to untangle whether there are linkages between toxic exposures and women veterans' reproductive health? And I also want to just affirm that many lay folks especially think of toxic exposures as being, in the Vietnam era, Agent Orange, and in my generation as burn pits. But as a reminder, there are also issues of I can't remember the acronym, but the firefighting foam used in many bases, and Camp Lejeune, and the fact that, I won't let my kids drink out of plastic water bottles, but when I was downrange, I drank out of water bottles that had been baking in the sun when it's over 100 degrees for days on end. So, and how do all of those exposures intersect in the body, in the reproductive system? And then to make it a little more complicated, is there a genetic component? I loved hearing Dr. Shaw mention wondering about how MVP can intersect with some of this research, but I'd be really interested to see that also intersect with things like toxic exposures research. So the final thing that I'll note is, from where I'm sitting, I'm often interested in VA policy changes and proposed legislation, and I'm often acutely aware of the fact that some of the proposals to change policy or legislate change here at VA are based on ideas that seem great, but not necessarily backed up by an adequate amount of data, even on, for example, how many veterans would that change affect? Are there higher priorities that would actually make a difference for a larger number of veterans who are experiencing something as a barrier to care, for example? So identifying research gaps that intersect with proposals that are already starting to percolate in the community to help shape and inform the direction that we go, or technical assistance that we may provide, and so forth. I don't want to duplicate any of the fantastic suggestions that some of the others have already mentioned, but did hear very loud and clear and completely support the need to focus more on intersectional issues, for example. Okay, I hope that was helpful. That was definitely more than one or two. Thanks for your patience.
No, that was wonderful. Thank you. I think that point about connecting research to the end user through the channels that people use, like social media, is so important for us to think about, not just journal articles, although those are critically important, obviously, for research as well. And I want to give Dr. Zivin also an opportunity to answer this question for her perspective. So Dr. Zivin, from your perspective, a couple of points that stood out to you in terms of future directions for VA reproductive health research. Dr. Zivit, are you able to hear us? And maybe you might be muted.
Me?
Oh, yes, now we can.
Okay, I guess my headset wasn't working, so you didn't hear anything I said. Is that true? No, that's fine. I was just going to say that I'm really grateful to be here, and also, it is a challenge to go last, although I'm used to it with my last name. That often happens. But anyway, I definitely agree with what my other colleagues have shared so far about thinking about issues related to, health equity and identity and a variety of other issues. I would like to raise just a couple of other additional ones that came out from today, and also in thinking about my own lens, I guess, that I bring to this, which is that, I'm a health services researcher by training. My PhD is in health policy, so I don't have a clinical background. And I come to this primarily from a mental health perspective, but also reproductive health. And so one of the topics that came up, and I was glad to hear VA thinking about, is severe maternal morbidity, and in particular, mental health and substance use contributions to those disorders. I think it's important to recognize and think about how we identify, address, and treat them. Another thought I had was that thinking about care coordination, I think we heard about in some of the presentations, how do we best ensure that women are getting, delivering individuals having continuity of care inside and outside of VA during, pregnancy, delivery, postpartum, and what do we know about that, the quality of care that they get access to, what gaps or barriers are they facing, and how can VA address them? I think it's also useful to consider the context of how VA is similar or different in how it faces challenges related to coverage, access, compared to, say, private insurance or Medicaid, especially as some individuals may experience access to more than one, in addition to lack of insurance. And so just thinking about some of those contexts, I too, like several of the other commenters here, am very focused on policy. My research tends to evaluate the impacts of policy on outcomes. And I think, as we've talked about, that can be, small p or big P type policies inside and outside the VA, and how that affects, individuals with dealing with a variety of conditions surrounding pregnancy and delivery. But I also very much appreciated our colleagues that spoke about the whole range of the reproductive cycle, including menopause and perimenopause, because I think we don't talk enough about those issues. We, often focus on the earlier phase of the reproductive life cycle. So I will pause there and look forward to hearing other comments and questions. I'm sorry about the mute button issue.
No worries at all. Thank you. I just in listening to all of you, and we could talk with each of you for an hour or more individually, and we have somewhat limited time. I wanted to do a follow-up question which touches on some of the things that each of you spoke about, and also a common theme that came up throughout the day. So we identified, our research today, our presenters identified many areas where there has been some work, descriptive work on the greater presence, for example, of PTSD or exacerbated menopause symptoms with PTSD, or other things that could benefit from some kind of earlier identification by the clinician or by the patient, or the clinician and the patient together. We also talked about fibroids, STIs. We had some questions in the chat about chronic pelvic pain, urinary incontinence, sexual function. So all of these things that could be better identified earlier, bringing up the idea that there's a role for research around clinician education and support, patient education and support, as Assistant Secretary Williams identified, how do we get information to veterans, also like systems, research around systems to better support this. Many of these things are interdisciplinary. We also heard about, we ask a lot already of patients and providers in clinical encounters, like in the office visits, and we can also think about how VA has been in many ways a leader in telemedicine. You know, telemedicine was established in the VA before the pandemic, and other systems rapidly caught up. And we heard from Lisa Caligari about the use of the sort of NIPOP using tech outside the visit, because in the visit or with a physical thing got to be too complicated. So this is a very long preamble, but my question is, if we think about the VA has some built-in structures that could support better use of technology and virtual care to do some of this education of clinicians, patients, and the system to better support, what are some ways that research could support this kind of systems delivering care, so we're not just putting yet one more screening onto the clinician or the patient in the visit? And I wonder if I could ask Dr. Zivin just to start first, and we'll kind of go in reverse order. Maybe if Dr. Zivin, if you have any thoughts about that, and then I can move to other panelists as well.
And sorry, to clarify, we're focusing on the potential use of virtual care and telemedicine. I just want to make sure I'm getting your question.
Yes, or even, you know, we heard about, and I'm not sure if you were there for this presentation, but Dr. Lisa Caligari detailed the use of a shared decision-making tool, which is sent by text using an established VA structure, VA text or vet text to get to patients outside the context of the visit, so that they come in sort of making better use of that visit. I'm just wondering if we could sort of meet the patient better where they are and the clinician, and using sort of research to understand how this could be better used.
You know, I admit it's not an area of my expertise, but at the same time, I'm aware of this type of work, both you know, inside the VA, but also in other clinics, you know, including here at U of M. You know, trying to be creative about best ways to meet the needs of individuals, whether it's between visits, you know, due to distance, level of care needed. Some people may need more frequent visits, but others may need less. You know, I think this idea of trying to pursue a range of options that could meet needs, and then, you know, speaking with my research hat or evaluator hat, trying to understand, you know, the strengths and challenges associated with trying those different types of care. Who does it work for? Who does it really not work for? What can we do to support people if it's not working, or get people the kinds of care that they need? You know, because some of that may involve helping support people with access to technology who either don't have access or are not, you know, technologically literate in certain ways. So I think, but in terms of trying to meet a diverse set of needs and timing, it seems to me like it would be an important idea to both try and think about sound evaluation of such processes.
Thank you. I wonder if, Kayla, if you have thoughts about that, just going back to your connection to getting information to the veteran through other channels other than the actual visit. I wondered if you wanted to elaborate on that at all.
Sure. I think as you were asking the question, though, I know this isn't exactly where you're going with it, but one of the things that I was thinking about is the PTSD treatment decision tool, and, you know, whether there are other ways that we can help provide more self-service decision-making, you know, guides or paths to veterans directly, to either, you know, help them make those decisions or make sure that they're fully armed with what they need to know when they have those provider discussions. And also that evaluation piece that was mentioned at the end of the last statement, I think is incredibly important, right? Like we need to build evaluation of these new tools in at the beginning to ensure that that they're working the way that we want them to, and that they're effective, or should we, you know, shift in another direction?
Great, thank you. And Amanda, I just wondered if you wanted to touch on this and maybe speak about some of the work that's going on in your office to support education around particularly chronic pelvic pain and patient and clinician education. It's been noted in the chat that chronic pelvic pain is tremendously prevalent in the veteran population and certainly interacts strongly with mental health issues. one question was, is there anyone doing research at that intersection? But I know that your office has sponsored some work around patient education, and there's some research that will be going on with that. I wondered if you wanted to describe that a bit for the audience.
Sure, absolutely. And I think you asked a really good question, and I think it's the right question. Is sort of how do we I guess I interpret your question as how do we engage or how do we encourage uptake of all of this information that we have, particularly about, you know, the unique needs of women veterans? How do we sort of increase uptake of veterans themselves? Just sort of awareness of these potential factors that may impact their health. How do we increase uptake of clinicians, sort of acknowledging this and then putting it into practice? And then how do we leverage our incredible you know, healthcare system that we have? And we really do have, you know, a large electronic health record. We have access to telehealth technology, all of those pieces. So how do we leverage it? How do we make the most of it for the people that we serve, for the veterans we serve? I guess to answer your question, so yes, we have put some pretty significant focus into pelvic health for veterans, with looking particularly at pelvic floor disorders. So that would include chronic pelvic pain as well as prolapse and urinary incontinence. I think that person who asked that question, Dr. Lambu, out of Orlando, has done tremendous work in this area, and she and her team have actually developed a website that is a both patient and provider, veteran and provider facing website, specifically addressing the issue of chronic pelvic pain, which, you know, I think we any of us who are clinicians here can acknowledge it's a complex issue. It's an issue that really requires a long-term multidisciplinary approach, and it also really requires establishing trust and engagement with the person who's experiencing it. So it's an excellent area for really an intervention that is both provider and veteran facing. And what Dr. Lonvoot's group did is they actually developed this website that is now available. It's on our VA for VA gynecologists here. It's available on our VA gynecology community practice SharePoint. The link is, and it can be shared with both veterans and patients, and it can be either self-directed, veterans and providers. It can be self-directed, so veterans can, you know, at their leisure, if they have a smart device like a phone, cell phone, or iPad or computer, can actually go through and watch videos and answer questions and do complete surveys. And providers can do the same, as well as access sort of additional information, handouts, things like that for veterans. So that's one area where we've worked to create additional material. We're also working on additional material for menopause, specifically with that focus on women veterans and experience of PTSD, and the way that vasomotor symptoms of menopause can mimic some of those same experiences of PTSD, the rapid heartbeat, that sort of feeling of overall flushing and awareness, sort of really looking at menopause through the lens of the veteran population. And again, you know, one of the things that we've really tried to do, and I feel like I'm rambling, so I'm going to apologize for that, but is as we look at each of these things, again, looking at it through an equity lens is really critical too. So I hope that answers your question. But I think you raised some great points with that. You know, how do we leverage what we have in VA? Because I think it's special, and there's real opportunity here.
No, that was great. Thank you to all of you. And I wonder, Dr. Zephyrin, given your perspective of working at the Commonwealth Fund and focusing on health equity and health systems, if you have perspective on other systems that do you think that the VA could take inspiration from, or maybe aspects of the VA, like we've touched on, that maybe are underappreciated and deserve more translation so that others can learn from, or that we might sort of focus on and strengthen in this general area?
Thank you. Thanks for that question. You know, I do think there's a lot of opportunity around this, you know, non-VA and VA coordination and connection. I mean, I think Dr. Maddox talked a little bit about this earlier in her work about how maternity care, and also even, I guess, Dr. Ryan talked about it with IVF care. Like there's a lot around the intersections, I think, and these transitions of care, I think, where we can learn a lot and do a lot and create a more seamless healthcare system for veterans that use it. So to your point around research opportunities, tools that really think about those transitions between healthcare systems and making those more seamless, I think there's a lot of opportunity for that. I mean, I'm just seeing more, veterans coming, utilizing VA health care services and utilizing other services at the same time. And so there's an opportunity there for transparency across systems so that so that other systems have a better sense of what services are provided at the VA and how to provide that care in a more seamless way for veterans utilizing the healthcare system. And the last thing is just relating to maternity care coordination. There's a lot of work being thought around postpartum care transitions, particularly as there are increased conversations around extension of Medicaid coverage through the first year postpartum and increased conversations around Medicaid expansion as well. And so I think that also, there's an opportunity there that I think there could be a lot of synergies in terms of what are best practices around postpartum care, around postpartum transitions that people could potentially learn from the VA and vice versa. So, and I'd say lastly, I know I said lastly before, but there's also a lot of work around birth equity and really thinking through equity, health equity in an intentional way. And just as, early on, with the Women's Health Program, really thinking about equity intentionally across gender, I think there's a lot that can be learned around using those examples of representation, centering community, centering veterans of diverse perspectives that can be applied across race equity as well. And someone in the chat wants a definition of equity. Happy to, I don't know, Dr. Patton, if you want to talk more about that, I'm happy to talk more about that too.
Sure, please go ahead.
Yeah, health equity is really being able to really make sure that you're really understanding perspectives and experience of care in an equitable way. And so whether you're talking about race or gender, or even if you're talking about disability or location, rural versus urban, for example. So health equity is a very broad definition. When I do a lot of our work on equity, or my work on equity, I also intentionally want to center racial equity as well, to make sure that we're thinking about the experiences of people across race and ethnicity, as well as gender and location, and the intersection between all of that as well. So equity can be broadly envisioned to really think about, historically marginalized and victimized, historically marginalized people. And we always have to center that in the work that we do.
Great, thank you so much. As a last question, I want to take a shift slightly, but stay kind of in this theme of thinking about diversity of ideas and approaches. If we think about research broadly within VA, we know that one of the benefits of working in VA is we have a diversity of disciplines all thinking about research. So from health services to clinical to even more molecular to even social sciences we've touched on. We have a vast diversity of methods. But one thing that I think all research systems could benefit from is increased diversity of the actual researchers themselves. And I'm wondering if any of you or all of you would like to comment on how we might think about building a more diverse research community within VA across kind of all the different ways we might consider that. would anyone like to take that question first? How can we build a more diverse, how can we foster a more diverse community? We certainly have parts of the VA that can support this, right? We have our Office of Academic Partnerships. We have residencies and other clinical trainees from a vast group of universities. We have medical students. We have other health professional students. How can we tap into these resources to create a diverse research community?
This is Kayla.
This is
I'll
Amanda.
jump in
Oh, go
very
ahead.
briefly to say, you know, I've thought a bit about this on the policy research side of things, and how, given that so much policy work is happening in the DC area, and I mean that more broadly than just VA health policy, I mean in general, and you know, the barriers are so significant to getting folks who are from outside the DC and do not come into the world with socioeconomic privilege, the opportunity to break into this space. Problems that range from, you know, unpaid internships to the challenges of the pay up on the hill if you want to get exposure to that side of things, and figuring out how, you know, say on the think tank side, to try to open up some of those pipelines and explicitly recruit in other universities than the ones that are, you know, right here and easy to reach to, how to try to get folks interested in funding that would support paid internships. I mean, this, I love that you're thinking about it from the VA lens, and we'll just echo that this challenge extends more deeply throughout the research world. And, you know, if we want to get philosophical or depressed, we could say, you know, extends all the way back to Head Start, and how do we make sure that all kids are getting equal educations in early childhood and more, right? And you've identified what I think of as a very wicked problem. And as you noted, I think VA does have some real advantages in terms of being able to conduct research all over the country in areas where some of those cost of living barriers may not be quite as high. And so identifying ways to get folks who come into the VA system excited about doing research and enthusiastic about collaborating with others, I think is a great opportunity.
Thank you. This is Amanda. I think that's something I've been thinking a lot about, especially since our recent VA Gynecology National Conference. You know, really want to make sure that the people who are actually doing the research also sort of represent in many ways, or you know, mirror in some ways the population that we serve. I think, you know, this obviously there's a big pipeline. You talked a little bit about sort of access. I mean, I think there's a piece of access to education, including higher education, and you know, there's really multiple facets of this, but I think one action that we can take as people who work in VA and do research, you know, in VA and outside of VA, is mentoring. You know, mentoring young scientists, mentoring people who come to us with ideas. You know, I think that's one step that's quite actionable. That, you know, and I think we continue to work for you know, change in the pipeline, but I think mentoring is a really powerful tool that we all have.
This is Lori Zuckman. I'd love to add, I agree with all of those points. I do think, you know, some intentional efforts around funding and supporting researchers is important, and particularly supporting researchers from diverse backgrounds. I think we often say we can't find the researchers, but there is an opportunity to sort of think short term and then long term in terms of addressing the pipeline, but in terms of short term, what are ways to support, provide funding opportunities, be very intentional about diversifying the workforce. The VA is an amazing place to do research, and I think it's a secret in many ways, and so it really requires some external effort to share the opportunities of research and that research operations link at the VA, and also provide additional funding opportunities to draw people to be able to do that in a meaningful way. But it is something that needs to be intentionally approached. It's definitely a challenge, but also an opportunity to be gained in terms of the work products.
This is Kara. I will, echo my colleagues on this point. I think outreach at all career stages and funding is key to support individuals. And the outreach, I think, is important because of what we've talked about lack of potential awareness or access. I wanted to highlight, this is maybe for people that are already fairly far down the stream, but I was encouraged to see in the last year the VA's Query Initiative, this ADIL, so Advanced Diversity and Implementation Leadership, as one way that was trying to promote early career investigators, both clinical and non-clinical investigators, to increase the diversity in those types of leaders. But it obviously has to start much earlier in the career stage as well in order to incorporate ideas. And I think, in reproductive health in particular, I feel like we could use a greater diversity in terms of gender diversity, in terms of, different backgrounds of who contributes to this work. So I'll pause there.
Thank you all so much. We're unfortunately out of time. As I said, I think we could keep going for many more hours. But I want to thank so much to all of you who have given so generously of your time to this panel and to this conference, and additionally to our audience for the wonderful questions and thoughts that you put in about these concluding questions. We're hoping that everyone is feeling energized about future directions for VA reproductive health research, even if we have identified some very, very big challenges. I would like to invite my conference co-chair, Dr. Jody Caton, to join me for a few final thoughts as we wrap up. And as we do that, I'd like to invite the audience to continue to put any ideas that you have for the question that you see on your screen. What directions would you like to see VA reproductive health research go in the next 5 years?
All right, thank you, Dr. Patton. And I really want to extend a heartfelt thank you to all of our panelists and discussants for sharing their work, their time, and their expertise with us. We know how busy you all are, and we are grateful for the commitment and generosity of the VA reproductive health research community and others who have contributed to this conference. We specifically also want to make sure that we acknowledge and thank Dr. Becky Yano and the Women's Health Research Network for their support of the Reproductive Health Work Group and their faith that we could pull this off in such a short time frame. Finally, we want to also be sure to acknowledge and thank our operational partners in the Office of Women's Health for their support and time in managing the Reproductive Health Research Network. Elizabeth, back to you.
Just to continue also our gratitude here, we want to say that our conference would not have been possible without the logistical support, the vision, and the savvy of Dr. Adriana Rodriguez, who's the program manager for the Women's Health Research Network, and also our colleagues at CIDR, including Heidi Schulter and her team. They've made this look very seamless and easy. So please, let's give a virtual round of applause to all of our participants and support staff. Lastly, we'd love to have interested researchers join the Reproductive Health Research Network. If you're interested, please just email Jody and you'll see our emails there. And if you'd like to subscribe to the VA Women's Health Reproductive Network listserv, you'll see the way to do that right on your screen as well. We want to say thank you all to the presenters and the audience members for such a successful kickoff to the Women's Health Research Network Conference Series, and wish all of you the best rest of your day. Thank you.